On behalf of Safe Motherhood Committee of OXY and all UP Obstetrics and Gynecology Society, I greet one and all to today's webinar. I'm Dr. Bharani, and I will be taking you through today's deliberation. Theory without practice is like a one-winged bird that is incapable of flight. That's what the father of surgery, Sushrita, said. Challenges keep cropping up in an obstetrician's practice. And as Sushrita said, we need to constantly keep updating our practical skills to tackle these challenges. Today, we'll be discussing some surgical challenges that we encounter in pregnancy and how to manage them from stalwarts in the field. But before that, we'll begin with a Tamil Thai Vartha. We'll now have the virtual lighting of the Kuthuvilakku to bring in brightness, prosperity, and enlightenment. I request our President OXY, Jairani ma'am, to give the welcome address. Ma'am needs no introduction. She's a senior consultant of reproductive medicine and director at Akash Fertility Center and Hospital, Chennai. She's also the treasurer of TAPISAR and associate secretary of World Association for Sexual Health Advisory Council member, World Association for Sexual Health, and member of numerous other prestigious organizations and recipient of numerous awards. Over to you, ma'am.
Thank you, Bharani. At the outset, I would like to thank my Safe Motherhood Committee for organizing this wonderful webinar with all the UP societies. And it is me a great pleasure and honor for me to welcome the chief guest, Dr. Sadhana Gupta Madam, who is a very dynamic woman, who is known for her wonderful knowledge, very much dynamicity, and a very active work what she's doing in FOXY. And we welcome her. Madam will be joining with us a little late. And I have the great honor. We'll have the introduction a little later. Once Madam comes, we'll introduce her again. With great pleasure and honor, I welcome Dr. Raki Singh, who is the chairperson of the FOXY Endocrinology Committee. Thank you, Raki, for accepting our invite to be the guest of honor for this webinar. And she's a very good friend of mine. Over the past 15 years, we have been a good friends. And she's working very dynamically in the FOXY. Can I have Raki Madam's?
Sahiti?
TV? Yeah. Yes. She's the vice chairperson of the UP state of EZAD. She's the peer reviewer of Journal of OBGYN of Jogi. And she had many awards and achievements in the publications. She has been an invited faculty of more than 350 congresses. And she has attended most international and national conferences. And she has the FOXY CS Dhawan Award at 65 ASCOG, which she got the first prize. and she has got the Foxy DC Datta Award for her publication of hepatitis B in women. And she has written many chapters in Foxy Focus and Jeffcott Gynecology, Fibroid Management, Izar Express, Dilemmas in
Thank you,
IUI.
Jairani.
And it has been a great pleasure and honor to have you, Raki, with us. And we would like to hear your words of wisdom.
Thank you, Jairani. And at the outset, I would like to congratulate Uttar Pradesh societies, all of them, joining hands with Safe Motherhood Committee of OGSI, and North meets South is there, and which is very good for all of us to communicate and understand what we are doing in the North and what we are doing and practicing in the South, and what is the culture and how we should go about. And to connect with North, there are many societies from North which are participating today, from Kanpur, Aligarh, Bulandshahr, Jaunpur, Gorakhpur, Noida, Greater Noida. We can have Dr. Sadhna Jaiswal Madam also from Greater Noida being there. And none other than Preeti Kumar, who's the Safe Motherhood Committee chairperson, who's already there with us. She's another great personality. And as a chief guest, we are having Dr. Sadhna Gupta Madam, who's there. And this topic, what we have, you people have chosen today is very good one. And many a times we are at a fix with the surgical challenges in pregnancy, whether to do it, whether not to do it, and how to go about, and what gestational age we can do it and what gestational age we are not supposed to do it. There are small gray lines and gray areas in between, which Dr. Chitra ma'am and the learned other speakers are there to explain it to us and give us the most valued information to know the guidelines and how to go about with all the main topics, like acute abdomen if the patient presents with, or let it be the urological conditions, or let it be the preterm births or the cerclage is what has to be there in place. And Foxy has been doing great work with all the great society people being involved. Apart from CMEs, the webinars are also very great to attend to many a times, where we do it at great length, and people can attend at their lease apart from the CMEs what they can do it. And I can see Sadhna Gupta Madam. Welcome, Madam.
Welcome, madam.
She's also joined over here.
Welcome, ma'am. Welcome, ma'am.
Welcome. And I would like to make a humble request that I'm standing also for ICOG Governing Council member. I request all the FICOG fellows and the MRCOG fellows to kindly please consider me and vote for me. I have been there working with academics all day long for all of you. Thank you, one and all. Do enjoy this whole webinar. Definitely it is going to be very fruitful. Thank you, Jairani and Kanchan. Best wishes for all of you.
Thank you, Raki ma'am, for this nice words. And definitely we'll all look forward for you as an ICOG governing member. And welcome, Sadhana madam. It has been a great pleasure and honor for us to have Dr. Sadhana Gupta, who has been traveling all around India like a flame. She's like a fire. She's going with her dynamicity, with her energy, and we are really very much amazed at her feat that she's traveling all around. Everywhere you see, madam is there. Madam, we really have a great pleasure to have you here for this webinar, to be the chief guest. Thank you for accepting our invite, madam. Madam is the co-chair of the Suffolk NCD committee. Madam is the Foxy representative of Suffolk between 2018 and 21. She was the vice president Foxy in 2016, and she's an ICOG governing council member between 2015 and 21. And she has got the best governing council award 21. And madam has been a corresponding national editor and a peer reviewer of Jogi as well as Suffolk Journal. And she was a past chairperson of Foxy Safe Motherhood Committee with Foxy. Dr. Magaruda Anhanasta Madam Award for the best committee award she has got. And she has been thrice representative to the WHO on women's health key issues, where she had done a lot of work on the quality RCH, essential postnatal and newborn care, and the Millennium Developmental Goal, which is the set goal, which she has worked a lot for the women's health. And she has achieved the 3 times a Korean award and award winner for the best scientific paper in 2002, 4 and 9. And she has got 4 times Best ASCOG Research Paper Award between 3, 4, 6, and 8. And she has done so much editorial of many books of this in the Safe Motherhood Bulletin. And she has been a key organizer for various national and international conferences from more than 20 years. And she has been honored with a lot of national and international forum for her exemplary work to reduce the maternal mortality and community services for the women and empowering the women. And also she has got the Foxy Padma Bhushan Kamalabai Hospital Award and also the Foxy Dr. R.N. Naren Malhotra Award also. And Madam has been awarded the Economic Times Award for services in COVID times in 2021. And presently she is the director and the senior consultant of the OBGYN Jeevan Jyoti Hospital Medical Research Center, Gorakhpur, Madam. Madam, we are really honored to have you here, ma'am, for your words of wisdom and for your kind felicitation for this webinar, ma'am.
Thank you, Rani, and thank you, Kanchan, for this invite. And I'm just a little bit noise if you are having. Excuse me for that, because I'm just just landed from the Jaipur, Delhi, and Delhi Gorakhpur flight. So first of all, hearty congratulations, Dr. Janani, Dr. Kanchan, for organizing these webinar and connecting what Rakhi was saying there. And this is actually one of the very, very important way that every professional body must have a very good, inclusive, all-inclusive presence, a diverse inclusion of the all clinical practices, the ways, and what is their regional specific need and what is the regional specific context, because it does not only enrich our knowledge, it does not only improve our widen our experience, it also make us a very powerful thought process in our professional body. So this is the and my all journey in the Foxy 30 years have been we have been like that, and my congratulations to you and the all involving team, my own sister Noida, and actually I am not at all which way because what all UP society, so I am totally the host of this webinar, and very my loving regards to Dr. Preeti Kumar and Dr. Rakhi, who has been a close associate since very beginning. We have been together, and we have been always encouraging each other, always guiding. So this has been a great association. My all regards to office bearer of all societies, all of our very, very close friend and a very, very active societies, my own society, and then the Kanpur, Shahjahanpur, Aligarh, and if because I am on the mobile, so excuse me if I don't take one or two names. So about program, very, very well crafted, because usually we don't discuss these things, the acute abdomen and cervical incompetence in the cervical circulation, because whenever there is a pain in abdomen, there is a lot of confusion between obstetrical and non-obstetrical cause, medical conservative treatment in dire emergency, when to do surgical treatment. And one very important thing is always that we are having so many ultrasound, so many ultrasound for the obstetrical region. We are many times omitting the upper abdominal scan, and we are really missing the stones and the the hydronephrosis and the extra abdominal and the liver changes. So I'm looking forward to the great discussion and the cervical circulation. A key change in our understanding, because cervix is now not considered anatomical incompetence, anatomical organ. It is a dynamic organ which have the the right protocol for assessing cervical shortening, right protocol for the clinical spectrum, and what other thing, infection, inflammation, and disturb microbiome, and everything can cause the cervical incompetence, and we have to be really looking for the case selection first and the technique. When we are switching to the abdominal procedure, so like, because it is a fashion, it is something glamour, it is accurate, but the skill of the good Shirodkar cervical cerclage is the thing which we need to nurture. Very, very interesting program you have like crafted. So I congratulate Jairani and Kanchan for this, and I wish you all the best for your election, upcoming election. Both of you are very, very dedicated person, very knowledgeable person, and this is the way that if the byproduct of election process is that you really reach the large number of people. What I was discussing, Dr. Jairani, and we were telling that it is something, a great thing which makes you much wiser and much open-hearted for everything. So with this, of course, my own societies and Jairani and Dr. TV Chitra, we have been always together. So I seek the presidential election is just 5 days ahead. And this is the time, actually, it is an earnest appeal that the presidential post or any post in the organization is something, a great responsibility, the great credential in the past. And this is a very, very earnest appeal that the person who have been shown the commitment, worked along for the federation, for the organization who have worked, and that person earns your vote, earns your love, earns your affection. And I appeal that everyone like vote for my Foxy presidential candidature. Together we can make a change with all inclusive, on involvement and all expansion for positive, promotive and protective Foxy. Thank you once again for this wonderful invite and sharing my few views. Thank you once again. And I best wishes to all office bearers and all faculties and all participants who are with us. Thank you.
Thank you, ma'am. Thank you so much for your lovely words, ma'am. And thank you so much. And we all wish and pray that your election should be a successful one for you, ma'am. And we are all, we'll pray God, and you will come with a lot of colorful way, ma'am. We definitely look forward, ma'am.
We all wish
Wishes
for
you, and with prayers, you will definitely come out with great colors, ma'am. Thank you, ma'am. Thank you, ma'am. Over to Kanchan.
Yeah. Thank you. First of all, this is my great privilege and honor to welcome such a great personality, OGSS. Thank you very much to make all the societies of the UP along with you. Dr. Jairani is there, and the chief guest, Dr. Sadhana Madam, has really given us the words of wisdom, and we all pray for her and for ourselves also. The guest of honors are the two really great persons that I know. Dr. Rakhi Singh, the chairperson of Endocrinology Society, very benign, very brilliant and hardworking person. Dr. Preeti Kumar, what can I say about you? You are a really great wonder. I have seen you. I met you during the time of Manyata at my center, and since then I am seeing what a great programs you are doing. हम तो आपके सबकी कायल हो गए हैं. Really, Dr. Preeti Kumar, you are most welcome as a guest of honor of today's program. I think by your presence, this will be a very successful program. We all need your support also. You are a co-chairperson at present of the Maternal and Perinatal Committee, SAFOG, a chairperson of Safe Motherhood Committee, Foxy, director of Sunflower Medical Center, Lucknow, and organizing
I think
secretary.
Dr. Kanchan will not waste much time because a lot of academics is waiting.
Many things of organizing secretary, and her great work I used to see, we all see. Just the mic is yours, Dr. Preeti Kumar, for your words of wisdom and wishes.
Thank you. Thank you, Dr. Kanchan. I think Dr. Sadhana and Dr. Rakhi has already shared whatever are my thoughts. But Dr. Jairani, I am observing you for last over a couple of months, or I must say. So I always try to, log in for your webinars, whether I'm invited there as a faculty or but I try to my best to join for some time and then leave that webinar. Not for that, but just for my own personal this thing. You are such a dynamic person, a very humble, down to earth person, and you have put lot of efforts. And I'm very confident that people like you should come up in Foxy. Like Dr. Sadhna ji, I've seen her working, I think, over past so many years. She was the one who introduced me to Foxy, and she said, Preeti, you have to come. And for last maybe over 20 years, she has been requesting me to come into Foxy. So it's step by step. And Dr. Kanchan, Dr. Rakhi, they're all, friends and very good people, and they are really working hard in their field. The topic which you have chosen, I must say that it is a need of an hour, and I can see faculty from even the surgical oncologist and other, I think, surgeons have also joined this meeting. This will be very useful. Foxy should take this initiative, and it should be a collaborative efforts when we discuss things like this, because it is a multidisciplinary approach. Whenever there is acute abdomen, it's always out of the domain of OBGYNs. So we should always, take help from surgeons, and most of the time, gallbladder stones and ureteric stones, they all create. And you have wonderful speakers. I can see Amrita sitting here, and so many, people. And I must congratulate Rajeshri, because she's so, particular about things. Every time she, puts a message, and she's so, congratulations, Rashi, you have a long way to go.
Ma'am, President Jairani Madam is behind us.
Yeah. It happens like this. When the leader is like this, the people will follow you. People will follow you. So for 24/7, for 3 years, I have not, slept properly. Just devoted my every minute to the community and for ensuring safe motherhood. And this is my, just whatever, sessions goes. But this is my humble request to everyone who is contesting here. Kanchan, Dr. Rakhi is going for ICOG, and Dr. Sadhna, of course, is going for president, and Dr. Jairani, you are going. Whenever you are selected as a chairperson or you take the responsibility, do your best, because this time will never come back. So the responsibility, people, trust you, and they vote for you, and they make you chair for some committee. Give best to that organization, and then leave that organization, so that you can leave the imprints, so that you can leave the footprints for people to follow. So I'm sure this webinar is going to be very useful, very helpful for everyone. And I will also try to log in by phone. I have to leave for a meeting. I have to go somewhere, but I will try to log in, because I really want to hear from surgeons whatever they are telling. Their inputs are very, very important. And I think there would be lessons to be learned from this thing. And thank you, Dr. T.V. Chitra, madam. You have also joined. Thank you so much. So good to see you here. Thank you.
Thank you, Preeti. Thank you for your lovely words. And definitely, as you rightly said, that we will definitely work as your wish, as you are doing. I'm really amazed at the work that you are doing with the emotion, with all the commitments and the dedication, and your passionate towards the work of your committee. Similarly, we all will look forward, and definitely, that's why I waited 3 years. First time I lost in the same committee election, but I had the passion to work for the same committee. So that's why I'm here. So we will definitely take your words and look forward and work with compassion and passion for the Indian women's health. Thank you, Preeti.
I know you will, Jairani, I'm sure that you will, you'll achieve success. But every time you fall, you stand up with more, vigor and with more strength. So it is better you fall and then you stand up. So that's give you more strength always.
Thank you so much. Thank you, Preeti, for the lovely words.
All the best to everybody.
Very special thanks to Rajeshri, because Rajeshri, I just want to tell a word about Rajeshri. I told her that this month we are having a webinar with the UP societies. Within 2 days, she's contacted almost all the societies, and she's so nice to formulate everything, the scientific content and everything. And really, I'm very proud to have her as my Safe Motherhood Committee chair. And whatever she does with perfection with utmost care and also with so much dedication and passion. And I really thank you so much, Rajshri, for your wonderful work of joining all together in a nice forum to feel very happy about the Foxians together, both the North and the South together. Thank you so much. And a very
Rani,
special thank-
all Safe Motherhood Committee chairpersons are very active.
dedicated. Yeah.
Whether they are from Oxy or from
Yes.
Kasoga
Yes.
or from Foxy,
Yeah.
they are very
Ma'am,
active.
she's our inspiration, ma'am. Gerard madam is our inspiration. We take it from there, ma'am. Thank you, ma'am.
Thank you so
All
much.
the best.
And
All
thank
the
you
best.
all the seniors here, Madam Jaiswal Madam, Amrita, Dr. Chitra Madam, everyone was immediately accepted and being a very important person of this webinars, which is a real great achievement of ours and the success of the webinar. Thank you so much, Preeti, and thank you, Raki, and thank you, Sadhana Madam. And really, we look forward with working you all. Thank you, ma'am. Over to Bharani for the scientific session done.
Yes, ma'am. Our honorary secretary, ma'am, was unable to join. She's the chairperson for the first session. So I think we'll just directly move on to what is a very befitting dialogue between a surgeon and an obstetrician. We're going to discuss acute abdomen in pregnancy, the non-obstetric causes. We have with us Dr. Naveen Alexander, who's a professor of general surgery from Sri Ramchandra Institute of Higher Education and Research, Chennai. Acute abdomen.
Bharani just asked. Yeah. Okay. Carry on. Yeah. Carry on.
Yeah. So acute abdomen is his area of interest, along with trauma, advanced laparoscopic surgery, and I think he also has a keen interest in obstetrics. Rajshri ma'am, our very vibrant head of Safe Motherhood Committee, ma'am's a consultant in obstetrics and gynecology at Sri Swasthya Clinic, Center for Women and Children, executive committee member of Oxy, chair Oxy Safe Motherhood Committee, with a keen interest in high-risk pregnancy, and she's a contributor to the Management of Labor 3rd edition textbook for postgraduate practitioners. Over to you, ma'am and sir.
Thank you, Bharani, and thank you, Oxy and Jairani madam, for giving us this opportunity, and all UP societies for joining with us. I now request Dr. Naveen to share his slides. First of all, welcome, Dr. Naveen.
Good evening, ma'am.
Evening. Please share your slides.
Yeah.
And this is taken mainly because we see that approximately 1 in 500 women will require non-obstetrical abdominal surgery during pregnancy. That is the incidence of the requirement of non-obstetrical surgeries. And so it's very important. And the most common non-obstetric surgical emergencies complicating are the acute appendicitis and acute cholecystitis. These are the two common. And other than that, we have other conditions, including the ovarian cyst masses or torsion, which we have already dealt with in adnexal masses during pregnancy. Cholelithiasis, adrenal tumors, clinic disorders, symptomatic hernias, complications of inflammatory bowel disease, and other rare conditions. Having said that, now I'm asking, the question is, as a surgeon, what are the challenges that you encounter while treating the surgical emergencies during pregnancy, Dr. Naveen?
Yes, ma'am. So the first challenge is invariably we are called as a last resort. So that is something that we always feel that whether we should have been involved a little earlier. But naturally, this is a very rare situation. As you said, 1 in 500 is not very common. But we are seeing, at least in my practice over the last 19 years, I have seen at least once or twice a year. To me, I end up in this kind of situation where a lady is pregnant, no matter whatever the trimester, where she needs some kind of a surgical management of an acute abdomen. So what it brings me down to is this. So knowing how further the pregnancy is important, because we need to know whether the viability of the fetus will be there, what will happen if we choose to treat it conservatively rather than surgically with a very high risk, and whether we need a good fetal evaluation. Another thing we have is, I think we'll be covering that in the slides as well, is a lot of the early pregnancy symptoms are very, very similar to what we have in acute abdomen as clinical manifestations. And it's invariably very tough to clinically differentiate between an acute abdomen and the normal pregnancy related symptoms. This is basically what really happens. So when it comes to this is what happens is, because there is a growing uterus with the baby in it, we have less prominent findings. Now, let's say when you have a patient who's got an acute appendicitis, we would have heard signs like tenderness and rebound tenderness. But invariably what happens is because of the gravid uterus, the findings in the abdomen are less, and there is lesser contact of the anterior abdominal wall and the peritoneum towards the affected organs. So you don't have so much of guarding that we see in acute abdomen. Okay, and also one of the key things, this is something that I go on telling my postgraduates, is whenever you're having a doubt during a diagnostic laparoscopy in an acute abdomen, follow the omentum and you will find where the source of the infection is. But unfortunately here, because there is already something very large inside the abdomen, the omentum is forced to stay where it is and it does not go and try to seal off whatever might be the acute cause of the pain. So yeah, so these are the situations that we will end up with when the patient comes to us. Yes, ma'am.
Yeah, and we have also seen that regarding the lab investigations, during pregnancy, the total count is already raised and it can go as much as 20 to 30,000 in early labor. So we do have difficulties in diagnosis. Going on to the next, are there any specific guidelines that you are taking up for management of these emergencies, acute abdomen?
Yes, and this is something that I always again say. It was prior to the early 2000s, it was very eminence-based medicine in this kind of situation rather than evidence-based. Thankfully, there is a very large surgical society in the United States, which is called the SAGES. That's the Society of American Gastroenterological Surgeons, but it's open to anyone in the world. And they brought out guidelines way back in the late 90s, and they've been revising this. So they have been doing a lot of research into this, basically how to approach acute abdomens in pregnancy. And every 8 or 9 years, they definitely update what they have been seeing. So if you look at this,
imaging modalities.
Yes.
Guidelines for imaging modalities.
Yeah.
Yeah.
So imaging modalities wise, we all know that there are certain things that we would prefer not to do during a pregnancy. But ultrasound, number one, is very, very safe. It's very, very specific. So that's very good. It rules out a lot of other things. And what we have to think about is this. If your patient has upper GI symptoms, then try to go ahead for an ultrasound as soon as possible, because it has a very good diagnostic accuracy of more than 90%. And we always know this is 100% safe. Okay, so next thing that they moved on to, is there any risk actually of ionizing radiation to the fetus? It is a well-known fact, and I'm sure that you'll all know about the teratogenic activities. But if you actually had to do a CT and you've ruled out every other thing with your different ultrasound scans as an MRI, then the radiation dosage should be very low. It should be maximum 50 to 100 micrograde. So if you look at this, now this is, if it's CT abdomen, actually turns out to be only 3.5 micrograde. I'm not saying they need, all patients can have a CT, but if you are in a situation where everything else has been done and you still don't know what is happening, then a CT might still help, and it can be done with a risk factor involved. So it should not be the imaging test of choice. On the other hand, MRIs are definitely becoming much more commonplace in the management of acute abdomen in pregnancy. And it's very safe in any stage of the pregnancy, as long as we remember not to give the contrast gadolinium. But that said, the usage of contrast gadolinium generally itself is being reduced overall in normal patients as well. So it might be a thing of the past. Yes, ma'am.
Next, we'll go to how do you select the patients for surgical management? What will be the basis for selecting what to do for whom?
Yes. So that said, we all know that open surgery versus laparoscopy, we can go on telling until the cows come home that laparoscopy is definitely going to be minimal invasive, minimal better outcomes, better hospital stay, safer hospital stay, early return to work. All those factors are definitely there. But in a pregnant patient, we have to take in much more things into consideration, namely One is the size of the gravid uterus. So that is going to be something that is a big role for us. Also, at what stage of the pregnancy it is, whether anesthesia is going to cause a problem. And there was a lot of doubt early in this early in the era of laparoscopy, whether pneumoperitoneum that we use, the carbon dioxide, can be harmful to the fetus. So all these were concerns which the SAGES guidelines have brought out, and they have created very good guidelines out of this to say that certain things are safe and certain things are preferably not done. So earlier we used to say that second trimester is safest, and this is pre-laparoscopy itself. This is from the 50s itself. It's been very clear that second trimester is the safest because the chances of preterm labor and delivery is lower and spontaneous loss is also lower. But over the time being, from the mid-90s onwards, definitely they have said that laparoscopy will play a better role compared to laparotomy. And the second trimester thing is not going to be holding good any longer. You can choose to do in any trimester. So this is as early as 2007 itself, they have revised the guidelines, and this is something that is changed a lot. This is the trimester part. You can operate it any trimester. Previously, they said keep the carbon dioxide levels of pneumoperitoneum as low as possible, but now you keep it as normally as possible. But the key thing to look at over here is the intraoperative monitoring. Okay, so previously they said serial maternal ABG should be done, but with the advances of, this is how science works, ETCO2 by anesthesiologists itself, you can maintain it and we can monitor the pregnancy, the mother and the fetus at the same time. So they're looking at the end-tidal carbon dioxide. Another thing that we originally used to think was whether an open technique of putting in a trocar, the first trocar, is the safest, but it's been proved over and over again, whatever you are taught and whatever you are comfortable, that is going to be the safest. So I'm a Hassan's man, but I know a lot of people who use a Veris happily in pregnancy and have not really having major issues. We'll move on.
Okay, having had this general idea, we will now move on to case scenarios. This is AP, 24 years primary gravida at 16 weeks gestation, presented to the ER with severe right side lower abdominal pain for the past 2 hours. She gives history of constant periumbilical pain for the past 2 days and also bouts of vomiting and chills, but there's no history of fever. She's had her routine blood test and also the first trimester screening done at Trichy, and they were found to be normal. And she has traveled to her mother's house in Chennai only 5 days back. On examination, her pulse rate is 88 per minute, blood pressure was 110/70, per abdomen uterus is palpable, 16 weeks, fetal heart sounds were heard, and abdomen is soft and there was tenderness on the right iliac fossa. We sent in for a total count, which came as 12,500 and polymorphs 80%, and ultrasound abdomen suggested acute appendicitis. Now, what next? We are calling you in immediately, Dr. Naveen.
Yes, so this is quite a common situation for us, especially where I work, where you have a massive load of patients and you have a lot of early to late pregnancies happening at the same time. So when the patients are screened and they say acute appendicitis, it sets off a lot of alarm bells in everybody's head. And luckily, I'm on call most of the time here, so I get called for these. And now, if we look at this scenario over here, I wouldn't be too worried about the counts per se. 12,500 is very borderline in this kind of situation. But the polymorphs definitely will make me feel a little jittery. So in this kind of situation, I would like to sit with the sonologist first of all and look at the ultrasound myself. I mean, I'm not a sonologist per se, I don't really do these, but I would like them to show me exactly what they have seen to classify as acute appendicitis. Second thing, I would mark it on the anterior abdominal wall where the appendix is likely to be. Okay, right? Third thing is, most of the time, these patients are already on a course of antibiotics. It's already been started. So they have been given preferably a second or even a third generation cephalosporin, right? And in spite of that, if the patient is still having tenderness, and this is something I take you back to a few slides earlier, where I said that the prominent findings are not there. So if I'm still able to palpate and cause some amount of tenderness, then I would say this is a good case. I mean, not a good case, a case suitable for a surgical intervention. Now, the reason why I mark it is in case the patient is too fragile for laparoscopy, then my incision is going to be bang on top of the marked area by open surgery, so that I can go directly in, just grab whatever is required, pull it out and come out. Okay, so that's it. Since we are a tertiary care center, I think laparoscopy is a safer option. So we will go ahead with a laparoscopic appendectomy. Now, this is a video from a few years ago. That's the liver, the gallbladder. Okay, what you're seeing there is an appendicular mass. That is your gravid uterus. I hope the video is flowing nicely. So there is a lot of inflammation in the right iliac fossa, maybe a little higher up as well. So I have to be very careful in placing my ports so that I don't cause any undue damage to the gravid uterus. I don't want to even touch the uterus. So patient positioning is very, very important. So we will put in a straight Trendelenburg, we will put the right iliac fossa upwards. Okay, and as much as possible, we will be avoiding any kind of energy sources as well. If I'm using energy sources in this situation, I would preferably use a harmonic scalpel rather than a monopolar cautery. Okay, so as you can see in this patient, there is a mass developing, and this is the tube, right? Tube is also stuck to the appendix. All these fellows like to go and hang around together. So especially on the right side. So once that is out of the way, I am able to identify the appendix. As you can see, that's the cecum. Okay, nice and white, but the appendix looks nice and angry. So pretty much after that, it's a pretty straightforward procedure. As long as there is no pus over here, I am quite safe. I can go ahead with an laparoscopic appendectomy. We'll move on then. So this is by far the most common surgical condition, and it's the most common non-obstetric surgical intervention as well during pregnancy. Okay, right? And I said labs, the counts is something that I would not be looking at too hard on, but I would definitely be looking at the polymorphs. And there is a lot of element of spiuria as well in these patients. And this is a lovely diagram, which is from, I think from an OG textbook itself, which shows you how far the appendix where it is supposed to be. This is the normal place for a normal patient, non-pregnant patient, but how it gets displaced like almost from the 6 o'clock position to the 12 o'clock position. Okay, and this is because of the growth of the uterus. So this is another reason why I asked for the I asked to be there when they're doing the ultrasound so that I can know exactly where that appendix is sitting. Thank you.
Thank you. We'll now move on to the second case scenario. This is a 26-year-old Mrs. A, gravida 2 para 1, live 1. She's had a previous full-term vaginal delivery. She's now 30 weeks gestation, and she comes in with a right upper abdominal pain and vomiting for the past 1 week and fever for the past 2 days. On examination, her pulse rate is 90 per minute, blood pressure is 110/70, temperature is 99. Uterus is corresponding to 30 weeks. It is not tense, it is not tender, it is relaxed. The fetal heart rate is 165 beats per minute. And we have feeling some tenderness in the right hypochondrium. Ultrasound was done immediately. The fetal growth corresponded to 30 weeks. Placenta was anterior, not low lying, and there was no evidence of retroplacental clots also. We have ruled out abruption. The LICA was normal, and the fetal heart rate was 160 beats per minute. On upper abdomen, ultrasound showed polylithiasis, gallbladder wall thickening, and pericholecystic fluid. Under counts, total counts were said 16 to 50 cells per cubic millimeter. How will you are called in, Dr. Naveen, now?
Yes, ma'am. So this is what I would. So initially, any case, and this is whether you're pregnant or not, we would preferably not operate. So that is something, okay, right? Because a non-pregnant patient, definitely has access to much more better imaging techniques in this kind of situation, like a CT or an MRCP, where they might pick up an empyema or a gangrene of the gallbladder. But unfortunately, we know in pregnancy, we don't really want to push for imaging like a CT in this scenario. So most of the time, we are trying to treat the patient as much as possible in a conservative manner. And this will be basically keeping the patient nilperoral, starting them on IV fluids and hydrating them extra compared to a normal patient. Okay, if the patient is throwing up a lot, of course, Ryle's tube insertion will be of very good use. But the key thing is to start on very good broad spectrum antibiotics. Okay, now when it comes to deciding whether surgery is required or not, and this is across the board, whether pregnancy or non-pregnancy, it is very, very controversial. So a lot of times we choose, and this is, I would say, more anecdotal rather than anything. I have done this on many an occasion where, in spite of the counts being even 17,000, 18,000, I have chosen to give 3-4 rounds of antibiotics during the pregnancy, and somehow waiting until the pregnancy is done, baby gets delivered happily, whether cesarean or normal, whatever it is. But the day that she finishes the delivery, I start planning for the proper lab coding. And this is something that is very, very important. As much as possible in this scenario, we avoid surgery as such, because acute appendicitis versus acute cholecystitis, we know by other evidence in non-pregnant patients, we can choose to treat patients with gallbladder problems as conservatively as possible, unless, of course, if there is empyema or gangrene, which is an immediate indication for surgery. So in a pregnant patient with features suggestive of empyema or gangrene, its imaging is very, very difficult to do. So in these patients who I have started the broad spectrum antibiotics and then still not settling down, I would consider surgery. Okay, so the thing is, we also have to remember that there is an element of pancreatitis as well in these patients, because if small stone has slipped out, then we are in a big soup. And dealing with pancreatitis in pregnancy is a whole much more difficult ball game, I would say. Okay, you need to be much more careful, and the pregnancy is also at risk due to the very severity of the pancreatitis. So treating, if I have decided it is surgery, then I am very, very clear. As regards surgery-wise, comparing acute appendicitis versus cholecystitis, cholecystitis is far more easy because you are completely avoiding the lower abdomen. So this is a small video showing the gravid uterus in the fore, and slowly I am trying not to touch the uterus, but I have to place my ports there as well. And as you can see in this case, this is a much older video of mine, way back 2012 or 13. Okay, right? This patient actually had an empyema of the gallbladder. So there was no other way I could handle this as such, except for going ahead with the surgery. Okay, as you can see, there's a lot of pus flakes around. It's a very heavily distended gallbladder, right? And the patient had a stone at the neck of the gallbladder. So the first thing we do in these kind of situations is to push out all the dirty bile by a suction, and then the surgery becomes fairly easy because below that neck, we will be able to identify the cystic duct and get away with the rest of the surgery. Surgery otherwise will be the same. The beauty of these things is immediately, the day POD 0 and POD 1, patient will revert to being just a pregnant patient and not having a surgical problem as such. They do very, very well. Yes, ma'am.
Yeah, we'll move on to the next case. 32-year-old Mrs. Yen, 9 weeks pregnant, came to emergency department with abdominal pain and vomiting for 2 days. She is a gravida 3 with previous 2 cesarean section. Her dating scan was performed 10 days ago, and it confirmed an intrauterine single viable gestation. On examination, abdomen, it was soft, scar was healthy. There was diffuse tenderness all over the abdomen and also gaseous distension. Ultrasound abdomen showed dilated bowel loops with collapsed distal ileal loop. So with this, we are calling you in, Dr. Ravi.
Yes, so this is a very, very dicey situation for the surgeon to be in, because now he is torn between two scenarios right now. So one of the key things that we are taught as a postgraduate in surgery, is at least in my time, was never let the sun rise or sunset on an intestinal obstruction. Thankfully, we have moved on from that. We try to treat these as conservatively as possible now. Okay, and we also have different medications which can help with promotion of the peristalsis past that obstruction. Okay, right? So getting to the diagnosis of obstruction here, our standard approach in a non-pregnant patient is to take an X-ray abdominal, which cannot be done in this scenario. So you need to have an exceptional a radiologist for you to pick up a good finding of intestinal obstruction, number one. And number two is a good history is also going to play a major role. That said, when you're looking at the scars of the abdomen, as compared to a Pfannenstiel versus a classical cesarean straight midline incision, I have rarely seen, let's say I've gone in for some other cause to do some other surgery. Most of the time with a Pfannenstiel incision, you will see almost nil adhesions. This is something, it's again anecdotal, I should maybe think of publishing this, but if the ones who have the midline scar invariably end up having more adhesions, whether it's bowel or whether it's omentum, really doesn't matter. But definitely the healing there, that midline scar is a little more excessive. So there is a lot of, so when I look at this patient, I will look at what kind of scar it will be as well. Okay, so once we have decided this is intestinal obstruction, first thing is to treat these patients conservatively, nil per oral. Then we are going to be starting the patient on IV fluids. We are going to insert a Ryle's tube nasogastric decompression needs to be done, and give it 24 hours to even maybe 36 hours before taking a decision on whether this patient will require any kind of surgical management. Most of the times it does settle down, right? And then we start them on graduated liquids little by little, and then we see how well they do. But the moment you feel they're going in for obstruction again, then we definitely need to plan for surgical intervention. So this is the same scenario where we had to finally go ahead, and thankfully this was a little different kind of scenario. So once we put in the laparoscope, we were able to identify lots and lots of omental adhesions. We've taken them down carefully, okay, right? And we were able to identify one band. Sorry, I'll just show you that. There was one band of adhesions. So as you can see, this is the dilated loop. Sorry, this is the dilated loop. That's the collapsed loop. And here I'm able to identify one adhesive band. All it needed was me to divide that with scissors and bipolar cautery, and that's all. It took us basically 10 to 15 minutes, but this patient went on to have a very otherwise successful pregnancy. So sometimes it takes a lot of guts, I would say, on the surgical aspect, as well as the anesthetist, as well as the obstetrician, to finally decide in these kind of scenarios to go in for surgery.
Especially in the first trimester when you have Yes. We'll move on to the next case scenario. She's a 26-year-old Mrs. RS, gravida 2 with 1 miscarriage at 24 weeks of gestation. She came in with complaints of pain upper abdomen with multiple bouts of vomiting following food intake. No history of headache. There's a previous history of acid peptic disease on irregular treatment. Her targeted scan was done at 20 weeks and it showed a normal study. On examination, her pulse was 88, her BP was 100/60. Per abdomen, there was tenderness over the upper abdomen, particularly epigastric region. Her uterus was corresponding to 24 weeks and the fetal heart rate was normal. Here, how do we come to a diagnosis and how do we manage?
Yes.
Because we
So-
generally, it's easy for us to
Yes.
say acid peptic disease, but then how do we think of other disease and how do we manage?
Correct. So differential diagnosis in this scenario is going to be number one, cholelithiasis itself. So that's definitely an ultrasound is indicated in this situation to make sure that there is no cholecystitis per se. If there are gallstones, if it is asymptomatic, otherwise, and let's say you can, when your history is taken, invariably they'll say, yes, I had some biryani yesterday. And so we need to, most of the time, the history will tell us exactly what might be the problem. And the treatment is going to be pretty simple at this point. So make sure there's no gallstones. And if the patient is having reflux disease, then definitely they're going to have heartburn. Now, again, these are symptoms that are very, very similar to what happens in early pregnancy. So it needs to be differentiated between the thing. Now, one of the things is whether they have had a previous history of acid peptic disease. So there is enough evidence to say that patients actually do not develop de novo acid peptic disease during pregnancy, because there is some amount of a protective factor in pregnancy patients in India. This is a wonderful paper. I will share it with you all. Okay. But if you see the West, where there have been evidences of people smoking during the early stages of pregnancy, then the acid peptic disease levels are slightly higher. So finally, when we know this is just acid peptic disease, what is our management? We, as a rule, for most of the time, we prefer proton pump inhibitors as compared to H2 blockers. But in pregnancy, and this is again data from many, many decades, that H2 blockers is by far better outcomes as compared to proton pump inhibitors. Now, in proton pump inhibitors, lansoprazole is the safest and omeprazole is the least safest. And this is only in animal studies. It hasn't been proved in humans yet. But I would say when you are dealing with two individuals here, the mother and the baby, I don't think you should be taking a risk of giving a drug which can be unsafe. So definitely H2 blockers plays number one. Now, what happens in a patient who's coming to you repeatedly with the similar symptoms? Now, this means it's a high chance that there may be a Helicobacter pylori infection. And when you are planning for H. pylori treatment, these drugs can cause a problem in the pregnancy. And because some of these will have Metrogyl, some of them will have clarithromycin, they might not be safe for the fetus at that point. So H. pylori treatment should be started only postpartum. It should not be started during the pregnancy itself, right? So that is something that we have to remember. Yes, ma'am.
We'll move on to the last case scenario. This is a 26-year-old primigravida at 18 weeks gestation. She presented with history of pain abdomen, loose stools, and nausea. On examination, her pulse rate was 100, blood pressure was 90/60, and she had a temperature of 100 degrees. For abdomen, there was minimal guarding and diffuse tenderness all over the abdomen. Uterus was 18 weeks and fetal heart rate was good. While examining, we just elicited the history and she gave us a previous history of lower abdominal pain with occasional nausea, and she was treated conservatively as a case of acute appendicitis. And she was advised interval appendicectomy. Patient deferred surgery and now she's conceived subsequently and she's 18 weeks now. So how do we manage?
This scenario is a real life scenario. It happened to one of my own MBBS batchmates. So this is the reason I put this up here. She ended up having a pelvic abscess, and unfortunately, she went in for an abortion. So this is why I was thinking what could have been done better. So initially, she had been advised as well for a ultrasound guided transvaginal / transrectal drainage of the abscess. So they went ahead with the transrectal and found the pus was too thick. Now, in this kind of situation, if the pus is too thick, it still needs to come out, and they should have gone ahead with some kind of a more invasive drainage method. Maybe a laparoscopy should have been done, or maybe even a laparotomy in this kind of situation. Because the last thing you want to have is a septic focus causing problems during the pregnancy. So I was researching the data on pelvic abscesses. It's very, very rare during pregnancy. It invariably is more a complication of PID rather than a surgical problem. And definitely everything indicates or pushes us towards drainage. So drainage, when it comes to having pelvic abscess or intra-abdominal abscesses during pregnancy, drainage is the way to go. There is no question of conservative management at all. As much as possible, remove the infection. So transrectally, yes. Transvaginally, yes. And also there is a role for laparoscopic drainage as well. Okay, so either way, get it out, because you don't want the pregnancy to be at risk. The problem with all these surgical conditions in pregnancy is, I told you, is there is a significant risk factor for the mother, the baby, as well as because the data, as I said, although we have guidelines here and there, the data is very, very less. And most of the times, I think if you are planning for a surgical management of a surgical problem, it does involve a lot of risk taking, lots of guts on everybody's part, including the mother. So that's also you have to, we have to appreciate patients also taking that wise decision. But either way, in 17 years, I've done 22 of these patients of acute abdomen in pregnancy, and majority of them have had a great outcome. Only one went in for a preterm labor at around 33 weeks. So, yes, ma'am.
Thank you so much, Dr.
Thank
Naveen.
you, ma'am.
We are done. Bharani, please. Thank you, Bharani.
And thank you for all for involving me. It's my pleasure. And Rajshri madam has literally spoken to me over the last few days more than my wife has done.
Sorry, Dr. Naveen.
I'm just kidding. Okay, thank you again for the opportunity, ma'am.
Thank you.
Thank you so much, sir. Thank you, ma'am. It was a wonderful presentation, wonderful dialogue. I think we got a lot of concepts crystal clear. Moving on to our next session, which is talk on surgical urological challenges in pregnancy. I'd like to welcome our chairperson for this session, Dr. Kanchan Sharma first. Ma'am is a candidate for chairperson NCD committee FOGSI, Secretary Kanpur Obstetric and Gynae Society 2021 to 2023. She's the president of IHRF Kanpur, ART specialist, laparoscopist and colposcopist. And she recently organized a mega event, WW NatCon. She's a recipient of numerous awards and is part of many national and international conferences. We're very happy to have you with us today, ma'am. And this talk will be by Dr. R. Srivatsan, consultant uro-oncology and robotic surgery, who specializes in performing robotic and minimally invasive urology, endourology, and reconstructive urology. He was a former consultant at St. Isabel's Hospital and presently at Apollo Hospitals, Chennai. His areas of expertise include robotic and minimally invasive urology, endourology, reconstructive urology, and robotic uro-oncology. He's got numerous publications and awards in his kitty. Over to you, sir, about the surgical urological complications in pregnancy.
In fact, thank you, Dr. Bharani. And this is my proud privilege to chair a session of such a brilliant speaker. I welcome you, Dr. Shiva.
Thank you, ma'am.
And the stage is yours.
Thank you, ma'am. Can I share my screen?
Your wonderful talk.
Thank you.
Sadhiti,
Dr.
Srivatsan should be allowed to share his screen.
Yeah, thank you. Yeah. I, on the outset, thank the societies for giving me this opportunity, Dr. Rajeshri ma'am, and all the holders of the positions to give me this opportunity to speak on this. This is not very common, neither is it very uncommon, and it's kind of like a difficult decision making many a times. I would like to, tell in brief how we would like to deal with the urological issues in pregnant women. Obviously, the consensus of whether to operate or not, whether it actually involves the role of urologist and so many other factors have to be taken into account. Considering that mostly my talk would be restricted to the surgical challenges, but I would like to involve the UTI also as the start of my talk, because that is the most commonest urological issue that you will be facing it in a pregnant woman. And it is definitely an important issue in pregnant women as well, starting from asymptomatic to symptomatic. Most of the times it will be associated with an obstructive uropathy, and that is where the role of the urologist comes into play as well. Second would be a VUR. The third is a urolithiasis, which is now actually increasing quite a bit. And this is the age group where the urolithiasis is common as well. LUTS in incontinence, I'm sure you, as obstetricians and gynecologists, you will be well aware of this. So I'm not going to talk too much about it. Incarcerated gravid uterus, again, not in my purview. And a little about urological cancers, because being a uro-oncologist, I do see a couple of patients with gravid uterus and urological cancers, and that puts a real conundrum in how to go about managing these patients as well. So we all know the physiological changes of pregnancy. It does have it on the kidneys as well, and that is where all the problem starts, including the physiological hydronephrosis that is a part and parcel of pregnancy. So increase in the cardiac output, the vascular volume, and obviously the blood flow increases by up to 65% of GFR increase in the pregnant period. Now we can see that the kidneys do increase up to 1 centimeter in length and up to 30% in volume, almost at the end of the gravid period. The physiological hydronephrosis is the biggest problem that as urologists we face, because we are unable to differentiate whether the hydronephrosis is pathological or physiological. I'll try to find out ways to understand whether we will be able to do that as well. The dilatation of the right side is quite common. The left side is usually protected by the colon. The right side is generally evident even by the 6th week end of gestation, and this is probably due to the harmonic effect of the progesterone. Progressive expansion at the rate of 0.5 millimeter per week until weeks 24 to 26, and then it slows down at a rate of 0.3 millimeter per week till term. We all know the mechanical extrinsic compression from second trimester due to the gravid uterus. Also, the engorged ovarian vein complex does cause a compression over the mid-ureter, thereby leading on to the physiological hydronephrosis as well. There are occasions when fetus in the breech position in the third trimester may compress and obstruct the mid or upper ureter. Now, this is not at the mid or lower ureter, but more so in the upper ureter. Dextrorotation of the gravid uterus may account for HUN being more common on the right side. The left ureter is generally protected by the thickened sigmoid colon. The hydronephrosis usually resolves completely post-mortem, though it may take about 4 to 6 weeks for the entire process to resolve back to normalcy. There are also some lower tract changes that we should be aware about. Obviously, the compression because of the the size of the uterus, the superior aspect and dome of the bladder does get compressed. It falls forward sometimes as well. In third trimester, definitely there is going to be a reduction in the bladder volume. That is why you're going to face the increased frequency, urgency, and all those symptoms that the patient is going to complain about. So these could be considered as a normal physiological consequences. You need not worry much about it, but it is imperative that we should be able to differentiate between frequency, urgency, and with the presence of dysuria and other symptoms, which could indicate a UTI as well. The stress urinary incontinence is also quite common. Almost like 3/4 of the multiparous women have an episode during pregnancy, but again, probably related to physiological, can be assigned as so. Rates of stress urinary incontinence does increase with increased parity and obviously previous vaginal delivery instrumentation and so on, the obesity as well. Now, this is one of the common calls I do get, prepartum, partum, and postpartum as well. It is not so common, but then it is 1 in 3,000 incidents. They do present to the emergency with pain and anuria. If it occurs in the early pregnancy, it is basically because of the progesteronic effect. It causes an intense relaxation of the urethra and the detrosa, thereby leading on to retention. And they are generally very comfortable, not too, too much in pain because of this. However, if there is due to an acute obstruction like a retroverted uterus at 12 or 14th week, especially if it is associated with fibroids or other, didelphys and kind of another abnormalities, then you're going to have an acute retention, which you're going to present in the emergency as well. In the third trimester, urinary retention may occur if there is an incarceration in the pelvis. Usually, again, it is associated with either previous surgery, fibroid, uterine abnormality, and especially, conditions like invasive placenta as well. Now, the treatment is quite straightforward. The worry generally the mothers and the obstetrician have is that, is it something temporary? Is it permanent? Is it, how to go about treating it? Generally, most of these urinary retentions, depending upon the cause of the retention, is usually very self-limiting. Usually they recur within a couple of days. Generally, it's an acute event which is spotted. We do have to do an ultrasound to find out if everything else is okay in the pelvis, but otherwise, it usually is self-resolving. We do had, especially post-delivery, we have had a lot of calls for, temporary urinary retention. And this is most probably due to one, even after cesareans for that matter. I'm not even talking about the normal deliveries as well, which could be associated with the episiotomy, the pain around that area and so forth. But even after cesarean, there is some kind of what you can call as a neuropraxia of the perineal muscle as well. So you do get a bit of retention. All that is required is a temporary catheterization for a couple of days. I do add a bit of alpha blockers in these patients, like tamsulosin, which will cause relaxation of the urethra even in the females, thereby letting them pee in a couple of days. We do give a little bit of bladder training and then do a trial without catheter after a couple of days, thereby leading on to the most of them, 99.9% of them do void, and there is no residual effect of the urinary retention. If there is some kind of still incomplete emptying of the bladder, we do teach them self-intermittent catheterization so that till the time they recover from the neuropraxia, it holds them good. The most important topic that I would like to insist upon, though it may not be surgical, is that the UTI. Now, we all know, and I mean, you guys must be the experts in the bacterial UTI in pregnancy. I do deal with them, and then I do get referrals for this very rarely, but then we do get this because of complicated UTI as well. As you all know, it's classified into ABU, asymptomatic, symptomatic lower tract, symptomatic upper tract. Now, the more that I'm worried about is obviously the symptomatic upper tract UTI, but the more that you guys have to be worried about is the asymptomatic bacteria and the symptomatic lower tract, because they will ascend over a period of time if left untreated. And as we all know, that bacteriuria as per se may or may not be associated with problems, but then anything which is symptomatic do have an incidence of IUGR, premature delivery, and so many other factors as well. UTI for us is a neurological emergency still, especially if it is coexistent with urinary tract obstruction, whether physiological or pathological. So any kind of an obstruction with stasis of urine is going to cause a little bit of bacteremia, and that is going to cause urosepsis. Urosepsis currently is one of the leading causes of mortality and morbidity in the world, whether in pregnancy or not. I'm talking generally. Urosepsis, especially in this kind of a diabetic population of India, is one of the most common cause of, they may be suffering from cancer, several other things, but they generally die of urosepsis is something we need to be cognizant about. So it's a very, very dangerous condition that we need to be very, very careful about. So we all know the gram-negative bacillus, GNB growth is the commonest, E. coli, Klebsiella, Protease, Enterobacter. Sometimes we do have gram-positive like Enterobacter as well. So this is something we need to keep under cognizance. We all know the risk factors: pre-existing diabetes, neurogenic bladder retention, quite common in pregnancy, VUR, kidney transplantations, which may not be quite common in the pregnant status, increased parities, and history of recurrent UTIs in the past as well. There has also been a lot of studies which says intercourse during the period, especially if the local hygiene has not been taken care of, can result in a UTI symptomatic as well. Why are we worried about it so much? Probably UTI not so much, but then it can ascend up to the the actual local immunity of the bladder, which is quite good in a non-pregnant uterus, is actually becomes slightly porous in a pregnant state. So there is increased permeation of the bacilli, the increased adherence of the bacilli to the bladder wall, and there is increased penetration. And we all know that there is a physiological reflex that occurs from the bladder to the ureter in the pregnancy due to the high pressures inside the abdomen. All this put together can lead to the ascent of the bacteria or the bacilli into the upper tract. And this is disastrous because the upper tract does not have the immune mechanisms or the defense mechanism that is so clearly seen in the bladder. So once it permeates that, and it's also a high pressure system. So once it permeates into the upper tract, there is a very high incidence of bacteremia. There is a very high incidence of, a lot of complications like perinephric cellulitis, abscess formation. It can lead to septic shock like urosepsis. Especially, it can lead to renal dysfunction, whether temporary or permanent, including AKI, and that is a very, very, very disastrous situation in a pregnant female as well. It can lead to hematological dysfunction. So anemia and thrombocythemia are quite common, especially when a hemodiluted patient. Thrombocytopenia is quite common as well. Now, thrombocytopenia and hypotension at the time of presentation are two of the most important prognostic factor at the time of presentation in urosepsis, and these two are poor prognostic factors. There is a very, very high mortality, associated with these as well. Hypoxic fetal events due to maternal complications of the infection that leading on to the microthrombotic episodes into the placenta. Preeclampsia has been found to be very much high incidence in the patients with recurrent UTI during the pregnancy as well. There is a definite possibility of a preterm labor and possible subsequent preterm delivery, leading to increased infant mortality and morbidity. And that is the reason why UTI during the gravid period is very, very essential. It has to be looked out for and has to be done. We all know the midstream urine collection. This has to be explained properly to the patient, because many times we get a mixed growth or a contaminant growth, and that leads us to nowhere in treating the infection properly as well. The treatment regimen is simple as this thing. Usually we give an uncomplicated UTI oral therapy with all these antibiotics. The recent trend of the antibiogram differs from city to city, hospital to hospital, and so forth. But generally, the resistant pattern is quite prevalent across the country. We are seeing more and more antibiotic, multi-drug resistant organisms as well. So we are actually going on to the higher and higher antibiotics like third generation cephalosporins, fosfomycin, nitrofurantoin, and so forth. Even we are seeing nitrofurantoin resistant these days as well. Now, coming to the second most commonest consult that we get as a urologist is for urolithiasis. Now, urolithiasis in general, especially in a humid city like Chennai, is quite common. The incidence generally is not so different from a non-pregnant female. The incidence of 0.03 to 0.5 is the general population prevalence, which is also seen in the pregnant female as well. It's nothing that it's increasing during pregnancy, though there are some physiological changes that can put already a compromised lady into a urolithiasis condition. Now, this kidney stones is also important because it has been associated with the increased risk of preterm birth, a lower birth weight of the child, preeclampsia, increased risk of cesarean section due to other issues, premature rupture of the membrane, and preterm delivery as well. So this is a very important this thing. It has to be taken care of properly, and it has to be and there are a lot of conundrums that we face in treating it, in diagnosing it as well. So it's very important that we be very careful about it. Left-sided flank pain and microscopic hematuria, prior history of stones were reported as statistically significant predictor of urolithiasis as well. Now, why do you see an increased incidence, though the incidence not so much difference, is because of certain metabolic changes, and I'm sure this is all physiological changes that occur, including vitamin D, increased calciuria in the urine, and also there is a filtered load of urinary citrate and magnesium stone inhibitors, which is usually present in the urine, are absent, thereby leading on to an increased risk of crystallization in the urine. There is also a respiratory alkalosis, especially in a very twin pregnancy and all, where there is an increased breathing exacerbation. So you do have leading on to the alkali excretion into the urine. Acidic urine is protective against crystallization, whereas alkaline urine can lead to both UTI as well as due to this thing. As you all know, that there is a urease enzyme that is secreted by the bacilli, which will create the formation of stones as well. Now, we always have the ever trustful ultrasound as the first bedside, even for a diagnostic modality. But the point being, it is very not so sensitive for a diagnosis of our stone disease. For us, the NCCT KUB is the gold standard for diagnosis of stone disease. Sadly, most of the times we will not be choosing NCCT in the pregnant female in view of the obvious reasons. So it is only 34% sensitive in finding ureteric stones, because ureter lies below all the bowel gases. So it is very difficult to penetrate the ultrasound wave across the bowel and identify this thing. However, we do have indirect signs which we rely upon in order to find out whether there is a stone disease or not. One is obviously characteristic colic history, which is quite obvious. Again, sometimes it may be slightly vague. Sometimes it may be associated with, something like a uterine kick as well. So it's kind of dicey sometimes where the history is kind of muddled for us to understand whether it's actually a ureteric calculus or not. We do have the presence of HU1, which is always indicative of something abnormal happening in the ureter. But sadly, again, physiological HUN is something that can occur and we need to be very careful. The right-left difference do help us make a decision, but not, scientifically conclusive as well. We do have other parameters in the ultrasound like, resistive index. Resistive index is basically the high pressure inside the vessels of the kidney that we measure. And that tells us to an extent whether there has been some obstruction, uropathy. Even though there is a physiological dilatation, there is no obstruction in pregnancy. So the urine does free flow into the bladder. If there is an obstruction, you will find the resistance in the resistive index. And that is what we use to find out whether it is actually viable or not. The second thing that we use is the absence of ureteric jet. Now, this is again very dicey because unless it's a complete obstruction, you are going to find some amount of urine come out of the ureteric orifice. So that is something very subjective. If you have an absence of ureteric jet, probably it is a positive finding, whereas the presence does not rule out a urolithiasis as well. Since there is a dilatation, usually the usual width of the ureter is generally about 2 to 4 millimeter. In the pregnant, it's almost the double. So a bigger stone can also be passed out. So generally, almost 70 to 80% with less than 1 centimeter stones usually pass out the ureteric calculus very easily. So not easily, with pain probably, but then it does pass out without any surgical intervention. And that is a very, very important fact to be remembered. And we try and tend to put most of these females on, conservative management in order to make sure they don't have to undergo a surgical management. The second test that we rely upon, if it is very, very inconclusive and we are not sure whether this pregnant female requires an intervention or not, is an MRI. MRU is a very, very safe and high quality image acquisition that we have that is very, very predictive. But sadly, MRI does not see the stone. Stone is basically invisible in the case of even soft tissues are better, but then stone is very invisible. CT is again the only test that can see the stone. However, MRI also rules out other causes of acute abdominal pain that can be the reason, like an ovarian torsion or an appendix, as Dr. Naveen had said. So this is an excellent modality that we use if there is a decision making in question. If there is a, for example, like a sepsis, there is a count rise, we do not know what is the cause of this count rise. It could be a pyelonephritis, may require a stenting. Then this is one of the investigations we do order before going in for a intervention. We do have a filling defect, but again, that filling defect could be anything that ranging from a calculus to a papillary necrosis. Papillary necrosis is not so uncommon in a pregnant female as well. As one of the commonest after, especially if the patient has a gestational diabetes. The very important limitation that we find is that the MRI ring, it's a claustrophobic machine. The ring is too small for many of the multiple gestation patients to actually go. It is really very claustrophobic, and that is going to have a very important effect of whether the patient can actually undergo especially in the third trimester. So I think this was discussed in the previous talk as well. We all know that ultrasound and MRI are quite safe. But when it comes to CT, the current NCCT that we do not use contrast. We do not use contrast in MRI as well, as Dr. Naveen said. But then the CT that we use currently, which is the fast acquisition image CT, NCCT, is actually around 0.4 to 0.8 exposure of the fetal radiation dose. So in cases where we have no other option and then saving the mother's life is a priority, especially in the third trimester, we do insist on a CT scan before an intervention, because doing an intervention without having an idea of what is causing the problem is like going in blind into an alley without understanding what we are getting into. So sometimes, very rarely, we do insist on an NCCT in order to make sure that we are on the right track as well. So what do we do if the patient has an acute colic or the patient is having a stone which is blocking the urinary passage? We do not do ESWL. ESWL is an extracorporeal shockwave lithotripsy. It's the easiest mode. Without surgery, we can break the stone from outside, but it is an absolute contraindication in pregnancy because of fetal death and malformation observed, especially in the first trimester. It's a shockwave therapy, so shockwave can bombard the uterus as well. It's very much contraindicated in all trimesters of pregnancy. This is to be about. Relative contraindications are also there. We generally tend not to use the stone breaking devices, like EHL is absolutely contraindicated. Pneumatic uses, sound waves to break it, or mechanical ballistic waves to break it, and laser. Now, these two have been actually set and put on the absolute contraindication list for a very long time. We no longer have the EHL. We do have the pneumatic and the laser machines. But generally, nowadays, we are more and more using the laser to break the stones. Initially, there was a confusion, even MCQ saying that there is a cyanide gas formation when the laser, breaks the stone, and that will is, detrimental both to the mother and the fetus during the pregnancy. But this has been proven null and void. Laser is generally the safest, one of the safest methods to break the stone. But generally, do we break the stone while we are intervening? Actually, we generally tend not to do that. We generally try to bypass the block by passing in a DJ stent or a PCN, diverting the urine. That is the more important, especially if they are more closer to the term date. We tend to just divert the urine, thereby, recovery of the patient, deliver the child, and probably do definitive management only. Then it is safer. But then, if, for example, you are not even able to pass a stent across the obstruction, we may have to have a ureteroscopy to break the stone, and thereby leading to better outcomes as well. So when we pass a DJ stent, the most common problem that we face is the frequent encrustation of the DJ stent. As I already said, there is an increased calciuria. You're going to have a lot of issues because of the deposition of the calcium on the DJ stent as well, including the nephrostomy tubes as well. Now, both uric acid is also increased in urine content as well. The optimal intervals change is what is very difficult. It is said that it's best that we change within 6 to 10 weeks. That is approximately 8 weeks. Now, this is a very tedious process every time changing the stent. So unless you are not able to deal with the stone, like if that is better or it is closer to the term, it is acceptable. But it is not acceptable during the second trimester when you can actually remove the blockage, put in a stent, and remove the stent in the next coming 2 or 3 weeks, rather than to put the strain on the mother to undergo the stenting every 6 to 8 weeks is not acceptable to me, at least. However, if the patient is on stent or is unable to undergo any further procedures, I would recommend a very good hydration, especially vitamin C, as supposed to acidify the urine and thereby create decrease in the encrustation of the DJ stents. I have used them, but then there is a dose limit in pregnancy. You can't give very high doses of vitamin C. I would restrict myself to less than 1,500 grams per day. So which procedure when to do? As I already told you, I would prefer, one, not to do a procedure unless it's absolutely essential. Two, divert the urine if there is an issue of doing a procedure by either a DJ stent, most commonly DJ stent. 90 to 95% of my patients get the DJ stent. Or if it is going to be a difficult a local anesthesia induced percutaneous nephrostomy or a PCN tube directly into the kidney, affected kidney, thereby draining the tube. The problem with PCN is that it's an extraneous tube. It's difficult to manage for a pregnant lady continuously, especially if it's going to be a long duration obstruction. So I would prefer an internal stent. The problem of the internal stent being an early encrustation. So we need to be very sure that we do not let that happen, because that's going to create more stones and more problems for them. As the ACOG and the ASA have published guidelines, whatever may be the trimester, there is no restriction if there is an emergency or a threat to a life due to urological obstruction or urosepsis as well. Elective surgery, preferably after delivery, or even at the time of the delivery, it can also be done. The third thing that I would like to talk about, for which I have had a call to go to the OT and so forth, is the abdominal placenta. Now, we all know the accreta, increta, and the percreta, and these are dangerous situations, which is very, very, bad to both to the patient and the obstetrics dealing with it. So basically, if it is going to be a percreta, then we'll have to, especially into the bladder, I'm not talking about the other organs. So it has to be a resection of the complete involved bladder wall and reconstruction of it. There is no other option. You touch it, it's going to bleed, and that's going to be a disaster. So it's better not to touch it, remove en masse along with the bladder wall or whichever organ it's attached to, and then take care of that organ rather than to plunge into it and land into trouble. I would rather say even not deliver the placenta, take out with the cuff of the bladder or something like that, and then re-establish the continuity of the bladder with an SPC with the suturing of the bladder as well. Renal tumors. We recently had a year ago when the patient presented at the start of the third trimester with a kidney tumor, which turned out to be a clear cell cancer of the kidney. The patient's age was around 32, probably some of the hereditary renal cancer as well. So we did, observe the patient with imaging. We did complete the delivery by a cesarean section. At the same time, we did a robotic nephrectomy to remove the kidney tumor, which was quite big, around 8.5 centimeter renal tumor as well. Now, this is very not so common, but then it can occur, and it's just some condition which we need to be aware about. The more common, which we are called as an emergency, is an angiomyolipoma, which is a common tumor in the female. As you all know, it's an angiomatous tumor, so it is filled with vessels. There is a syndrome called Wunderlich syndrome, which basically there is a retroperitoneal bleed, instantaneous rupture of the AML, especially during pregnancy. One of the reasons that is said to be is it's laden with progesterone receptors, and during the pregnancy it grows. It grows like tremendously, doubles its size and ruptures, thereby causing an intense bleed. And this is very, very important, and we need to take care of it. Many a times we can't do an angioembolization in this patient because of the contrast, radiation, and so many other factors. Land up in a surgery, may lose the kidney if the bleeding is very severe as well. So we need to be very, very careful. We tend to try to save the kidney by doing a partial nephrectomy if possible, but again, it is generally a messy situation where the life versus the kidney makes a lot of difference as well. The last thing that I would like to talk about is the trauma during delivery. The most commonest call that a urologist gets is generally a bladder injury, which is very common. The incidental bladder trauma cesarean section is about 0.28%. Previous abdominal surgeries, previous cesarean section, prolonged second stage of labor, cesarean hysterectomy have all been associated with the bladder trauma. We have a classification of grade 1 to grade 5 bladder injury sequence. The most commonest site of bladder injury is generally the dome, which is attached to the lower segment of the uterus. But then we have had, in plastered bladders to the lower segment, we have had cut across the anterior and the posterior trigonal region of the bladder as well. So any form of bladder injury is possible, especially in cases of emergency seizure where we are in a hurry, especially if the fetal distress and so forth, that there is an increased chance of bladder injury as well. Repair of bladder injury is usually straightforward. Most of our obstetricians do minor bladder injury repairs as well. It's basically a double layer closure with an absorbable or a delayed absorbable sutures. Currently, my preference is a PDS rather than a Vicryl. Reduces the amount of infection due to the non-braided nature of the sutures. But in a injury that is involving the trigone, this is kind of difficult. You need to identify the ureteric orifice. You need to catheterize the ureter by either a DJ stent or a ureteric catheter. We need to generally have an SPC. Now, there is a question that most of our obstetricians ask me, why SPC? Why do you really need it, and so forth? Generally, when you have a major injury of the bladder, and as you all know, the bladder wall is quite vascular, we do have some form of hematuria post, suturing of the bladder or a reconstruction of the bladder. Now, if you have even a big sized catheter in the bladder, there is a chance that it may get blocked. If it gets blocked, then it's going to cause a distension of the bladder and going to cause a basically a rupture of the bladder at the suture line or a dehiscence as well. In order to prevent that, it is imperative that we decompress the bladder two ways. Thereby, even if one catheter gets blocked, you can always do that. And the second advantage, we can do some kind of an irrigation and drainage with the help of two tubes. So generally, we prefer as a urologist to have a double drainage before we do that. We can, even upsize the catheter on the lower end if it's a minor injury, but in major injuries, we do prefer to have a dual drainage as well. The other injuries are not so common. Ureteric injury is very, very rare. I've never had very rarely had a call for that. But then usually it occurs when there is a lateral extension of the uterine incision and there is a lateral bleed. In the process of hemostasis, sometimes the ureter, if it is very close to the uterine border, can get injured in that as well. The first step that we take is to make sure, one, the hemorrhaging is stopped, and second, make sure that the ureter is dissected on either ways. There is a very high chance of vascular injury, especially if you're using diathermy and other things as well, including vascular clamps. So we tend to have important this thing. Always this ureters will be stented. Probably a resection and anastomosis of the ureter can also be done. If it is in the distal ureter, the most common surgery that we do is a ureteroneocystostomy, where we just put the ureter into a new place in the bladder. VVF, again, nowadays, I think it's becoming more and more uncommon. Thank you so much.
Thank you so much, sir. I request Kanchan Sharma ma'am, our chairperson for this session, to say a few words about this elaborate talk. Before we move on to the panel.
I think this was a perfect talk, and usually we do face these type of situations. You covered each and every aspect, starting from obstruction to urolithiasis to many conditions that we usually do face in our practice. The talk was perfect, and even we usually have in the initial first 3 months obstruction, urethral obstruction, acute retroverted bladder, and patient come to us for curing the obstruction. We do put catheter and patient get relieved. So thank you very much for elaborate talk.
Thank you.
Thank you so much.
Thank
Now
you.
we'll
Thank you,
move on
Srivatsan. Thank you so much for that elaborate talk. You
Thank you.
covered almost everything about the nephrology with pregnancy, and really, it's a very great one. I just want to ask you only one question.
Sure.
Does the catheterization sometimes for many cervix very short for a preterm labor? Sometimes we put a catheter, we put a silicone type of catheter. Sometimes, how long the maximum duration that we can keep the catheters? Because sometimes the patients, when the cervix is very short, almost sometimes we have to put it continuously. So what is your input on this? How long can we do during the pregnancy? Is it a different way with a normal or non-pregnancy, or is it anything special?
So there are 3 different types of catheter. One is the silastic catheter, one we have the silicone catheter, and the third type that we generally use nowadays is what is called as a Bactiguard catheters, which is coated with heavy metals, which is supposedly said to prevent the incidence of UTI as well, especially the biofilm formation onto the catheters. Now, as you rightly asked, is there a difference between a normal catheter life and in a pregnant female? The only problem that we face during pregnancy, as I said, is the amount of sedimentation and the crystallization that occurs is slightly higher in the pregnant due to uricosuriya, calciuria, and so many other factors. So that is the only thing that we need to be cognizant about. The general lifespan of a silastic catheter is about 4 to 6 weeks max. A silicone catheter about 6 to 8 weeks max. And probably Bactiguard is similar as to 6 to 8 weeks. So this is the general tendency, the life of the catheter that we usually advise, not more than that.
Thank you. Thank you.
Thank you very much.
Thank you, Dr. Srivatsan. Thank you so much.
So moving on to the much awaited panel discussion. Before that, I'd like to introduce our chairperson for the panel discussion, Dr. Namrata Bharadwaj, consultant, Bharadwaj Nursing Home and Laparoscopic Center, former assistant professor of Jain Medical College, Aligarh. She's won several awards for paper presentations in the Kamini Rao Oration for North Zone at Calcutta. Ma'am is currently the secretary, Aligarh Obstetric and Gynae Society, and founder secretary of Aligarh chapter of ISOPAB. I'd like to invite the moderators for our panel today, Dr. T.B. Chitra Bhatt, ma'am, professor and unit head, PSG IMSR, Coimbatore, Tamil Nadu. She's a UG teacher and teaching teacher for almost 20 years and has got several accomplishments, including the Best Teacher Award by the Institute and past president of Pubai OG Society. Welcome, ma'am. And Dr. Sadhna Jaiswal, Senior Consultant Obstetrics and Gynecology with a rich 37 years of experience. She is the President of Greater Noida Obstetric and Gynae Society and Senior Consultant at Apollo Cradle and Spectra, Greater Noida. Our esteemed panelists for the panel discussion today, Dr. Amber Khan, Director Consultant, GHK Hospital, Jaunpur and Secretary, Jaunpur OBGY Society. Dr. Amrita Sarkari, she's from Jaipur Medical and Research Center and Garg Hospital, Gorakhpur, UP. And she's the President, Gorakhpur Obs and Gynae Society and Secretary of the Gorakhpur Menopause Society. She's also present in numerous papers and recipient of numerous prestigious awards.
Thank you, doctor. That's okay.
And Dr. Aradhana Singh, she's the President, Noida Obstetrics and Gynecological Society and Additional Director, Obs and Gynae from Fortis Hospital, Noida. Dr. Shweta Mathur, she's an experienced orator and speaks on women's health and wellness for various MNCs. And she's in clinical practice for the past 20 years and is running the Srijan Clinic in Noida for the past 11 years. Welcome, ma'am. Dr. Uma Jaiswal, the Honorary Secretary, Allahabad Obstetrics and Gynae Society. She's an aesthetic gynecologist and obstetrician practicing for more than 25 years. Welcome, ma'am. And Dr. Samita Gupta, currently working as Senior Consultant and Professor, School of Medicines, Medical Science and Research, Sharda Hospital, Greater Noida. She's the Secretary of Greater Noida and Obs and Gynae Society.
Thank you so much.
Dr. Shubha Pandey, Head Obstetrics and Gynecology, Kamala Nehru Memorial Hospital, Prayagraj. She's also the President of Obstetrics and Gynecology Society, Prayagraj, and renowned professional experience of more than 40 years in Obs and Gyne. I welcome all the panelists and over to Chitra ma'am and Sadhna ma'am for the panel discussion.
Can I share my slides?
Yeah, I would like to thank the organizing committee for giving me this opportunity. And I'm really very glad to join this academic amalgamation of North and South India. Yeah, and we are going to have a very great time. Yes, Dr. Chitra, please start.
See, at the outset, I would really like to thank Dr. Jem, the Oxy Society and all the UP societies for having joined in. Like Madam said, it's been wonderful to see the fusion between the North and the South. And I welcome all the panelists. Dr. Jayarani and Dr. Rajshri have done a wonderful job. And at the outset, I would like to really congratulate them for this wonderful achievement. It's been great to put all the societies together, so many societies from the UP. So that's really wonderful. And I would also like to wish all the contestants for coming out in flying colors. I hope all of them get what they want. Now, it's an honor to have Dr. Sadhna Jaiswal from Noida as my co-chairperson. I bring greetings from Coimbatore, and this is where I work. Now, just a few words before we go on to the most important topic. Now, this preterm delivery, nobody would like to have a baby like this who was delivered at 29 weeks with around 800.
Ma'am, your slides are not seen. Slides are not moving.
So,
please make it full screen, no?
Yeah, I've made it full screen.
Yeah, please.
I have made it full screen. It's not.
But
No, ma'am, it's
1 minute. I'll just do slideshow board, madam.
Yeah, please.
Put on the slideshow board. Yes. Yes. See,
no,
ma'am.
no.
No, you just have to click the slideshow, ma'am. You haven't clicked. Resume slideshow. You have to click. Double click, ma'am. Slideshow. You have to click double. Look, I have. Resume வந்துச்சு madam. Resume slideshow வந்துச்சு. I think you have to click.
Ma'am, while sharing the screen, you need to click on screen window, ma'am, so that
See.
Top left. After clicking on share screen.
Okay.
To the top left, there is screen window. So if you click on that and share. Yeah.
Oh, she's still not on slideshow. Yes, ma'am. Click on that, ma'am. Double click.
Okay. No. You haven't clicked, madam. You haven't clicked it. You have pointed it, but you haven't clicked it. Right. Okay. I did click it. Okay. But the same slideshow that you have to click it. 1 minute. I just watch it. Sorry. Because I did the rehearsal and then it came correctly. Yeah. Now maybe that pointer is not clicking that properly. Okay, not yet.
No, ma'am.
Not yet, ma'am.
Ma'am, click the wine glass below.
Yeah. That you go down and click the down, ma'am.
Go down and click the wine glass, and then there's a slide sorter, there's a window kind of thing, and next there is a wine glass kind of a thing.
Ma'am, right lower of the screen, just see there are 4 dots are there.
Yeah.
And by the side of that, there is a glass kind of thing. Just double click on that.
No, 1 minute.
A single click would do.
No, this is just an.
Sagiti.
Okay.
No, ma'am. No, ma'am. Not yet.
God. It is actually, you might have opened another window, ma'am, probably. Okay, wait. So you will be seeing.
Ma'am, close the PPT, ma'am. Again.
Yeah, you close the PPT again and then open it, ma'am. That will be better. Sorry for the. No problem.
No problem, ma'am. You do it, ma'am.
No?
No,
not it.
you have not
started. You haven't shared. Okay. You haven't shared your screen. Okay, 1 minute. You might have opened a lot of windows, ma'am. Probably that's the reason. the share button and then another share button there in your monitor, and then you go for the PPT, ma'am.
Okay, now slideshow.
No, it's not in the slideshow, ma'am. Yeah, you click the slideshow, double click, madam. Yeah, now come to the beginning. Yeah. No, ma'am. No. You just click the slideshow. Now you click the yes. Click, ma'am.
Click, ma'am.
Click the right click. Yeah. Now come from beginning. You just or one more click there. You can
To the left,
from the
there is
beginning.
No. No, you click once and start from the beginning. It's coming, no, ma'am. You click it one. Yeah, you come to the from beginning. From beginning.
No,
you
but
go
here,
back.
this is the place where we don't go for slideshow, isn't it?
Yeah, but you have to double click, ma'am. Double click it, or you click once and come to the double click it, madam.
Yeah.
Oh,
No, even you can go down there because that also can be possible.
no, but I did it earlier and then it came. I can't understand.
Yeah. See, ideally it is coming, ma'am. Only thing you have to click the slideshow, double click. Yes.
Ma'am, if you click on the screen option and share, it will be easy, ma'am. Instead of going to PPT tab, if you click on the screen option,
Share. You have
and
to share and then click, ma'am. Yeah. You first share, madam. First share the click and then you.
Okay, I'll just share. Now?
Yes. Yeah.
Perfect.
Perfect,
Yes,
ma'am.
yes,
Perfect,
yes.
perfect.
Yeah.
Sorry for the delay. Yeah?
No,
Okay.
it's okay. It's okay. Yeah,
Yeah.
please.
Okay, fine. So none of us would like to have a baby like this, which is born preterm at 29 weeks, and the baby is in ICU with a lot of tension for both the parents and for the obstetricians. Now, we're just looking back to the facts. We have found that India is the largest contributor to the preterm deliveries, and it's the onus of all of us to see that this does not happen. Now, one important cause of preterm delivery is cervical insufficiency. And ACOG has defined cervical insufficiency as an inability of the cervix to hold the contents of the pregnant uterus. Now, coming straight over to the questions, we know that encephalitis is one of the most commonly done procedures during pregnancy. But in spite of it, there's a lot of variation in the technique, what are the indications, what are the suture materials that we use, and what is the care that we give after encephalitis. So there are so many esteemed panelists that in fact me and Dr. Sadhana are getting scared because so many HODs, all of them are there. So we have not put only the questions. Now there are many reasons for miscarriage, but we have to come to some diagnosis. What could be is this particular person having a miscarriage because of cervical insufficiency? So could one of the panelists, Dr. Amber, can we start in alphabetical order? Madam, would you tell us when all will you think that it could be a case of cervical insufficiency which is causing the miscarriage? And also, the next question also, are there any risk factors which would predispose them to cervical insufficiency?
Good evening, ma'am. Ma'am, we'll think of cervical insufficiency if patient is giving a classical history of recurrent pregnancy losses, especially the mid-trimester or the early third trimester losses. And the history is particularly consistent with the cervical insufficiency, like it is painless and sudden expulsion of the fetus. There is no bleeding and there may be copious amount of discharge because of the loss of the cervical mucus plug. And obviously there are risk factors which we must look upon very carefully. Even with the primary gravida patient also, we should inquire very well about the risk factors. Could be congenital or acquired. Like in acquired, there could be mechanical injuries to the cervix in the form of repeated cervical dilatation, or there is cervical conization or LEEP procedure done previously. And even, ma'am, sometimes the incorrectly repaired cervical laceration during the postpartum period is also a very important cause in subsequent pregnancies. And even the emergency cesarean section, which is done at the second stage, that is at the full dilatation of the cervix, is also a very important risk factor. And ma'am, some new theories also suggest that there is some variation and changes in the vaginal microbiome, which can also lead to changes in the causing cervical shortening, leading to cervical insufficiency.
Well, thank you, Dr. Amber, for having told us all the listed out all the causes. So one of the most important things, like you said, is preterm delivery or an early second trimester or a late second trimester abortion. Now, like you said, all the risk factors, but you said some repeated dilatation in a primary gravida. Why should a primary gravida have repeated dilatations?
Ma'am, not in primary gravida, like in any patient.
Any patient with the repeated, because there are cervical lacerations and that is good. So conization, I mean, it's not caught up much in our country, but in Western countries, conization, etc., is very, very common because they have extensive screening programs. But, and again, trachelectomy also is being done outside, but not so much in our part of the country. So now, like you said, it's very easy to look for cervical insufficiency when the person has had a previous history, because she's come with a history of preterm delivery or early 16 weeks abortion, and then you know, okay, this particular person has a high risk of having a recurrence. But it's very, very difficult to identify it in the first pregnancy. Don't all of you think so? Is there any way in which can, unless the person has any risk factors like a conization or Farthingales where she's amputated the cervix or something like that, it's very, very difficult. An index pregnancy, it's very, very rare for us to identify or suspect that she might be having a cervical insufficiency. Take her through a case which we had very, very recently. But before that, what are the guidelines as to when all we can do an encerclage? Dr. Amrita, ma'am.
Yes, ma'am.
How are you?
Yes, ma'am. Look, good evening, ma'am, and thanks for the opportunity given. So there are certain guidelines when there can be the reason after taking a proper history. There can be reasons by ultrasound and ultrasonic guided reasons when we find a short cervix less than 2.5 centimeters. And also, when we can see the cervix dilated and the back bulging, we can do a rescue cerclage. And if there is a history, as Dr. Amber already enumerated, that she has had repeated preterm deliveries, or she has had an operative delivery in the past, like a forceps delivery or something of that kind, where she has had cervical tear, or she has had repeated DNCs, conization. So if we get a history like that, then we can perform a cerclage. If in twin pregnancy, the cervix is shortened by 1.5 centimeters, then we can do a cerclage and rest when the cervix is less than 2.5 or the back is seen. Yes, ma'am. These are the guidelines.
Thank you, ma'am. So roughly the guideline is you will do it in a history indicated encerclage, or you will do an ultrasound indicated encerclage, and also when in the emergency encerclage. But the top guidelines, they say we do an encerclage if a person has had 3 repeated preterm
consecutive. Yes, ma'am.
Now, the other one is ultrasound. Suppose this person has had a history of preterm delivery, and then the next pregnancy she has an ultrasound and it shows a short cervix, then you do. That's an ultrasound indicated, like you said. And the third one is when she comes as an emergency. Now, my question is, now all of us have, I mean, we are supposed to follow guidelines, but there are no guidelines as far as our country is concerned. Now, would I mean, everybody, all of us, would we agree when we say you should do an history indicated encerclage only if there is 3 miscarriages? All the panelists could, does anybody, suppose she's had one history of preterm delivery, would you all do an encerclage, or would you wait for the 3 miscarriages?
No, ma'am. We will not wait.
Okay.
We
so
will not wait for that.
anybody differs?
Ma'am, here I'll differ. Hello, ma'am. I'm Aradhana.
Yeah.
We'll do it.
Yes, ma'am. Dr. Archana.
With the serial USG guide. Serial test of USG.
With one preterm delivery, I will not go with the just history indicated cerclage. I will wait for the ultrasound findings of the cervical length and serial monitoring of the
So one you will definitely not go.
Also for the
2 or more you would go. Okay. So now, let me come straight to the case. She's a 30-year-old lady, married for 4 years. She doesn't have any risk factors. She's a primary gravida. She's had an anomaly scan. This is a case which just came up last week. She had an anomaly scan done on 19/6/23 and which showed a cervical length of 3.6. Our scan center is very good, and then they've done a proper scan, a TVS, which showed a cervical length of 3.6. Now, 1 month later, on 21/7, she presented with lower abdominal pain. When she came to us, the cervix was 5 centimeters dilated. Now, what will you do now? Dr. Seema, ma'am, are you here, ma'am? Dr. Seema?
No, she is not here. She is not here.
Dr. Seema is not there. Dr. Shubha?
First of all, we'll admit the patient, counsel her, explain her the risk. Then we'd like to give a, this is an emergency. So we have to.
So now, ma'am, the cervix is 5 centimeters. So yes, you will definitely
5 centimeters. So whatever has to be done fast. And maybe the thing which will stop it will be a rescue encerclage. And we'll take a high vaginal swab culture at that time only, because she's already gone into contractions. She's having labor pains. So there is definitely a role of tocolytics as far as I am concerned.
So you
not
definitely want to take her for cervical encerclage. So now
rescue encerclage is indicated.
Okay. Now this was a picture on the theater. You could see the bulging membranes. You're really not able to see the cervix at all. You could see the bulging membranes. Now, when the cervix is dilated to that extent and bulging membranes, is it ideal for rescue encerclage? Would everybody take her up, or would you say, okay, no, the cervix is dilated so much, I will not be able to succeed and allow her to abort?
Obstetricians keep on trying all the time.
Yes, so you would definitely keep on trying. What about Dr. Uma?
Ma'am, it is saying in the books even after 4 centimeters. We should not try it for this class, but we can take the chance with the detailed consent to be taken.
Exactly.
For the infection, for the delivery, then we can go for that.
So at least you could try and see what best can be done for the patient, because for every pregnancy, even if she's a primary gravid, that's a precious pregnancy for her. Now, could anybody tell me at this level, when you're able to see the membranes which is just coming out through the cervix like that, the cervix is fully effaced, how will you do the procedure? Could anybody tell me? Anybody?
Ma'am,
who would like to answer? What is the, can you just change the names? Dr. Sweta? Is it?
Dr. Samta, ma'am.
Samta. Okay, Samta, doctor. Yeah, tell me. How will you do this? I'm sure all of us would have done this many times, but in this particular, when you put in the patient in the lithotomy, you're seeing the bulging membranes. How will
ma'am, in the Trendelenburg position, that is important. Then we have to fill the bladder. That is going to help us. Then for pushing the membranes, we can either use the moist sponge, small stick, or we can use a Foley's catheter, 30 ml. With a 30 ml saline, we can slowly push it so that the membranes are advanced go inside, and then we can put the cerclage, McDonald's cerclage can be put in that situation. So first we have to put the membranes back inside. That is the most important, and these are the things we can do to push the membranes inside, and that needs to be done very, very gently so that we do not rupture the membranes.
Very good, rightly said, because if you're in a hurry and try to push the membranes, there are chances that you would rupture the membranes. Now, you said about Foley's. Can you tell me a little more in detail? You have the Foley's catheter. How will you put the Foley's? Are you going to put the Foley's into the cervix and inflate, or outside and then push the cervix?
No, ma'am. We will first of all push the tip of the Foley slowly inside. And simultaneously, if we are not able to do it, then we can even take a small peanut and put slight pressure. Slowly and slowly, they recede inside, and then we can fill the bulb of the Foley's with 30 ml saline. 30 to 40
ml enough? Would you like to put some more? Because so much of memory.
30 to 40 ml is, I think,
what size of
Foley's
enough. Would you like to use, ma'am? What size of Foley's catheter would you like to use?
Which number?
Yeah. Which number?
Ma'am, around, I would like to use around 16 number of Foley's catheter, I would like to use.
Around 18 size catheter.
18, yes, ma'am.
Bigger size would be better. 16 might be too small, so a bigger catheter could be used. And sometimes, because the Foley's might slip off, you could use a guide wire. You could just make a nick and then put in your ordinary, or we had the sound, you can just put it in so that you can just fix it inside, and then you can fill the catheter. Now, would anybody else do anything differently? Any of the panelists? This is what is normally done everywhere.
So, ma'am, very rightly said by Samta, raising the foot end of the patient in the lithotomy, like that is Trendelenburg, would help the membranes to go back. And apart from that,
so how long are you going to keep the patient like that? Before
so, ma'am, as long as we are using, I mean, we are able to take the stitch around.
Yeah. So, in the what anesthesia? Yeah. What type of anesthesia would you prefer? Would you prefer GA or spinal?
Any
GA is
better, but
patients, yeah.
Okay, so under GA in the Trendelenburg position with the full bladder, you see that the membranes go inside. If it doesn't, then you use a moist or even a moist sponge can be inserted. Yeah. Now, is there any pre-op preparation? Because I think Dr. Amber was saying there's a lot of infection, which is the cause of person going for cervical insufficiency. So, would you check for infection at that point?
Yes, ma'am. We would send a high vaginal swab for the patient as soon as we see the patient. And then we can give a pre-op antibiotic as we gave the test dose and the full dose during the operation theater. We can give that.
A TLC and a CRP would be
TLC and CRP, yes, ma'am.
Okay. Now, in the guidelines, they say you
but
can
no recommendation, ma'am. The guidelines do not recommend any
amnio reduction. So, would
No,
you
ma'am.
advise? Would you do or not?
No.
No, ma'am.
No place of this.
Ma'am,
we will
but
not-
firstly,
Ma'am, because
amnio
reduction can
there's
even
one is to
introduce
reduce
infection.
the amniotic fluid, the membranes which is bulging, to reduce that. And the other one,
No.
they say you take the amniotic fluid and then send it for culture. So, it is there in the Green Top guidelines. But I do not know. Anyway, I'm not doing
It
that.
says that the role is not clear.
It's
No.
controversial role of it.
So,
Actually, it will make the bag less tense. It will make the bag less
Otherwise, it's
tense.
not done as routine to do an amnio reduction. Okay. So
ma'am,
now,
but excuse me, ma'am, may I say something? Ma'am, at first we should assess the fetus. There should not be any anomaly in the
Exactly.
fetus. Ma'am, that is the most important thing we need to do before doing
because
cerclage.
this person has had a scan, anomaly scan earlier. But if she comes, there's no point in trying. So there are certain contraindications where you will not to do. So Dr. Amrita, could you just tell me the contraindication when we will not proceed? But like when you said when the baby has any anomalies, any other contraindications?
Yes, ma'am. If she is bleeding, ma'am, if she's the membranes have already ruptured, then also we won't be, if there is severe infection or foul smell, then also we will not be doing chorioamnionitis, etc. Then also we will not be doing the cerclage.
So, but this cases which fits into the criteria for taking her up. Okay. So now, so rescue and cerclage was done successfully with this patient with the same method that we did a Foley's and then we put an encerclage. Now, is there any place for tocolysis? What type of tocolysis would you give and any place for it? Dr. Sweta?
Yes, ma'am. Ma'am, generally for history indicated and ultrasound indicated.
No, for this case,
yeah.
this particular
In this case, we should give something like we can give capsule Depin. We can give 20 mg repeat after 30 minutes, and we can see till the uterine contractions stop, because she is in labor, 5 centimeters. She is in labor. For this patient, we should give. We should keep the patient in hospital also for 24 to 48 hours, and when the patient settles, then we can stop the tocolysis. We can give it for short time.
Would anybody give anything else differently? Any other?
Atosiban can be given, ma'am.
Atosiban. If you have Atosiban, it's expensive, but it's worth giving because it's a very, very precious pregnancy. So could give. Has anybody used Atosiban?
Yes, ma'am. I've used. Yes.
And even isoxsupreme can also be given. We can give it.
So how would you give it? How much? What is the?
Ma'am, it is 10 milligram thrice a day to thrice a day.
Because you're taken up to the theater, so you would like to stop the contraction. So it should give a little larger dose.
IV.
Normally, you give around 40.
Ma'am, in a drip, yes, we can
40
give.
milligrams in the drip, and then you can run the drip. Yes. So that the contraction stop. Now, actually, you can also give indomethacin also as a drug. 50 milligrams can be given. So one of the tocolysis to be given because that would stop the uterine contractions. Like I said, there is no need to continue the tocolysis. Now,
excuse me, ma'am. Excuse me, ma'am.
Yes.
I'm sorry to interrupt your panel discussion, Chitra, ma'am.
Yes,
in our setup at Medical College, we had a thesis of tocolysis by nitroglycerin patch. And I would like to know your take and Madam Sadhna Jaiswal's take on this. I'm sorry to interrupt the panel, it was going so beautifully. But since you were talking about tocolysis, so I thought I'll just...
Madam, I've also been looking frantically in our hospital. We don't have NTG. Even yesterday also, we were trying to see, is there an NTG patch for the... I was asking the cardiologist if they have the NTG patch, so that we could try it for a patient with preterm labor. So I have not used it much, but I've seen 1 or 2 patients having the NTG patch, and it does work well. So unless we do an RCT, I will not be able to comment much on that. But it
One
might
of our
be
candidates
it's not available easily. Now, I think in this condition, we should need a tocolyzer which acts very fast and quickly, because we can't be waiting for a long time. And now we've done this encerclage at 5 centimeters altitude. Would you tell the patient some problems? These are the risks that you could anticipate. Dr. Amrita, could you like to take one?
Sorry, ma'am.
Any complications?
Complications, ma'am. There can be a failure of the encerclage, and we can rupture the membrane while we are doing the
important complications.
cerclage. We can
bleeding,
Infection. A patient can have infective morbidity to the mother and as well as the baby.
Yes,
so unless you tell them all those things, they're going to ask us, why do you do this? So it's very important that you counsel these patients before doing the encerclage. Now, in spite of all these efforts, in fact, after the cerclage, the cervix nicely closed. In spite of everything, the patient went to labor after 48 hours. And then we removed the sutures and she expelled a baby of 700 grams. Suppose we had kept her for another few more weeks, maybe we would have got a baby of maybe 800 grams. The baby might have survived another 2 weeks. But the baby was only 24 weeks and the baby could not be resuscitated. So now, so that finishes the first scenario. Dr. Sadhna would take on the next case. Ma'am.
Thanks, Dr. Chitra. Yeah. Now this same patient comes after 6 months with 2 months amenorrhea. So how will you manage her in the first trimester and what extra risks would you like to give? Yeah. So Dr. Samta, would you like to tell us?
Ma'am, in this case, since she already had this kind of a history, so in this case, extra drugs, I would like to put her on progesterone. We can either give a 17-hydroxy progesterone every weekly, or even we can go in with a vaginal progesterone. And this patient ultrasound monitoring with TVS needs to be done every 2 weeks minimum, and at 12 to 14 weeks, since this patient already has this history, so I would like to go in with a history-based encerclage at 12 to 14 weeks of pregnancy in this case. Ma'am, but as per the guidelines, since this is her first, so they might not, as per the RCOG, though she's not a suitable candidate, she might not be a suitable, but still I would preferentially go in with the history indicated cerclage in this case at 12 to 14 weeks. As per the guidelines, you can do a TVS.
Okay, before giving cerclage, I just want to ask, anyone wants to add on what precautions you will take?
Yes, ma'am. First, we will do a level 1 scan.
Yeah.
Yes, yeah, ma'am.
So, ma'am, I would not, first of all, I would not give it the one preterm delivery. Whatever said and done, it was the first preterm delivery. There might be the cause of infection, maybe the cause of that preterm labor. So with this good cervical length of 3 centimeters at 13th week, I will just follow her up with the serial ultrasounds and weekly. And then accordingly.
What else would you like to do? Yeah. Initially, just listen to me, one person. One more thing we can. Initially, just my question is this: initially, this patient has come to you at 2 months. He's only 8 weeks. Yes. Now, what is next? What next you will do? What investigation you would like to do?
So, ma'am, at
8 weeks, yes.
8 weeks, rule out any infections, any vaginal discharge if she's saying, or just inspect the vagina. For that, and after that, then again that this 12-week ultrasound would be done. A good progesterone support equivalent to the cervical encerclage. That is
not only ultrasound. We need a good combined antenatal first trimester screening is needed. So dual marker and ultrasound. Yes, correct.
So, ma'am, progesterone and the cerclage has been proven to be equally effective in these patients.
This patient started pain.
And ma'am, we
We
will
need a
also
serious
counsel the
sonographic
patient.
surveillance.
This
Yes.
patient,
Yes,
Tell
ma'am.
me.
this
Ma'am, we
patient
will
had
also.
pain.
One by one,
He
only
came
one
in
person. Yeah,
with
Dr. Uma,
pain.
please. Dr. Uma, please. Yeah, Dr. Uma, yeah, tell me. Mhm.
Dr. Uma?
Dr. Uma is there?
No.
Okay, okay.
Hello.
Oh, ma'am.
Yes, ma'am.
Yes, please.
Complete antenatal screening with infection and hyogenal swab and double marker with anti-scan. We should do completely. Then if there is no infections is there, we will do serial ultrasound. Also for diabetic screening. It should be must.
Yes, yes.
And serial ultrasound and progesterone I am already given. It is equivalent to like a circulars.
So how frequently you want to monitor her with the sonographic surveillance?
Fortnightly.
How frequently you want to do?
Fortnightly.
Fortnightly, correct. 2 to 4 weeks we can see. Yes.
Yes.
Yeah, the next question. So now is she becoming a case of ultrasound indicated circulage? Suppose if you see, what are the indications with the ultrasonography when you want to give a circulage? Dr. Shweta.
Okay, so less cervical length via transvaginal scan within empty bladder less than 25 millimeters identified before 24 weeks of gestation will be an ultrasound indication.
One thing more, Dr. Shweta, I want to ask you, Dr. Uma, can you mute yourself? Yeah, Dr. Shweta, one thing I want to ask you, that why transvaginal
because
measurement of the cervical length? What is the advantage? Why not transabdominal? Yes.
Because in transabdominal ultrasound, the pressure we apply on the probe can change the dimension and also how full the bladder is. If the bladder is not full, we cannot see the cervix via transabdominal scan. But if the bladder is over distended, the cervix may falsely appear to be shorter. So it is always better to do a transvaginal scan.
Okay. And also, transvaginally, sometimes, the presenting part, when we are doing transabdominal, if the patient is obese, then it is very difficult to assess the cervical length. And next, sometimes you see the presenting part also while you are measuring the length of the cervix. So better is to do a transvaginal scan. Yes.
Scan. Yes.
Correct. So what method you would choose?
So
Dr. Aradhana? Dr. Aradhana, can you just enlighten us with your answer? What method will you choose? Suppose the cervical length is less than 2.5 centimeter. So now what do you do? It's around 1.5.
So I would like to assess what gestation she is in. So if she's less than 24 weeks and 1.5, then I can consider. The circulage operation. Otherwise, I can just discuss with her, explain to her that she is in the high risk, and with a good progesterone support and adequate antenatal care, she can go ahead.
Now she is ultrasound indicated circulage. That is there. So which method you like to use in this case? What method you want to use?
So, ma'am, mostly we use McDonald stitch. So that is the most common which we all do. So that is the first.
What is the other one? What is the other one?
Shirodkars, in which the bladder is pushed up and the high circulage is applied. But mostly what I do is the ultrasound.
Yes. So correct. This is at the discretion of the surgeon. We do McDonald, but purpose is that you need to put the stitches as high as possible. That is the purpose. Okay. So, and the results are equivalent with both the methods. Either you do McDonald or Shirodkars. Yes. Now, Dr. Amrita,
yes.
Could you please tell us about the material used and the needle? Yes.
Yes, ma'am. In the Shirodkars one, we use the tape. The Marcelin tape is used, and we can use the Prolene also. We can in the McDonald stitches, and this is the tape which is used for on the left hand side. We have the one for the Shirodkars, and on the right hand side we have for the McDonald's. We can do
Ithibond can also be used, ma'am, and
Silk
can also be used.
And the muslin tape is also very useful. Very useful.
It can be used for the McDonald's also.
Yes, from
Marceline
McDonald.
tape is good, ma'am, because it won't cause the injury.
McDonald can
or the
also
cut
be good. Yeah,
through.
yeah. McDonald
Yes.
can also be good, and the removal is also easier.
Easy.
Yes. Yes. Yeah. Next, Doctor. So, what advice you would like to give, Dr. Amber? Could you please tell us? Post-operative, what advice? The rest, exercise, work, and what else?
Ma'am, usually we have to individualize as per the case, because all the guidelines, they do not recommend on bed rest, and ma'am, also the abstinence from sexual activity should also be advised, because there may be prostaglandin and all can be released, but it is not recommended, ma'am, in the guidelines.
Yes, correct. As per RCOG, a nice guideline.
Yes,
the bed rest and the sexual abstinence is not recommended. But again, this is as per your individual choice. You have to see whether the contractions are there. I mean, you need to guide the patient individually. Yes. Next. Now, when will you remove the suture? Dr. Samta.
Ma'am, at 36 to 37 weeks of the pregnancy, we'll remove the suture. And during the labor, if we do not remove the suture, then there are chances of cervical lacerations. There can be cervical tears. And if there is very advanced labor, even rupture of uterus can also occur. So these problems can, and the patient can end up into a traumatic PPH also with these cases.
Correct.
Any other problems during labor? Because you put a stitch, sometimes when you remove the stitch, you see that there is some sort of cicatrization where you put the stitch.
Yeah, ma'am, sometimes when we are trying for a vaginal, sometimes there can be that the cervix doesn't dilate. So that can also happen because of the fibrosis which the stitch can cause. So sometimes these patients might land up into a cesarean.
But this usually happens in Shirodkar stitches. It doesn't happen in the
Not
McDonald.
in McDonald. Correct. One more question I want to ask you, Dr. Amita. Could you please tell us? Would you like to do this transcervical length measurement in every primary gravida? And if yes, then from which period? At what station? Period, yes. In every patient, you want to do a cervical length measurement?
Yes, yes, ma'am. In every patient, it should be done.
At what gestation weeks?
At ideal time is 13 to 14 weeks, ma'am.
Correct.
We will do it with the anomaly scan also.
Yes, so universal stringing of the cervical length should be done, because many times we see a primary gravida comes suddenly with a precipitate labor, like the rescue circulage needs to be done. So yes, now Dr.
So
Chitra,
that sort
next
of
question.
completes what are the different methods and how do you do the clutch.
McDonald
what's the
and
follow-up of these patients. Now the same person, she's had an NSA clutch, she was sent her home. We did the NSA clutch around 16th week, because initially when she had the NT scan, the cervix was 3 centimeters, and then 16 weeks follow-up scan showed a short cervix, and that is when we did the NSA clutch. Now, when she came back for the 20th week scan, we found that the cervical length was 1.6 centimeters and there was funneling. Okay, so this was how the cervix looked. There was funneling and the cervix was short. She's already had one NSA clutch. She's only 20 weeks. Would you do a repeat NSA clutch? Or would you just say, okay, I've done the NSA clutch, I will not do, I will only give you foot and elevation and bed rest? Dr. Sweta.
Yes, ma'am. So, ma'am, I have never done a repeat clutch for a patient, but in this.
No, we will not go ahead, Shweta.
We will not do. Yes, all of you all could give your opinion. What would you do?
Ma'am, we will not give. We will not
do. Dr. Amrita.
Ma'am, we can put her on progesterones. We can give her hydroxyprogesterone, 17 hydroxyprogesterone weekly, which is as good as a NSA clutch. And we will do a high vaginal swab. We will check for the infections, and we will check for the urinary infections also. And
okay, so you're not
even the guidelines.
Conservative.
Aradhna. Yeah.
Conservative management with good progesterone support, ruling out the infections, treating any vaginal infections is the
with the role of tocolysis.
Dr. Amrita.
Yes, ma'am. Yes, ma'am. Even the guidelines do not recommend the double circlage, and they do not show any advantage over the single circlage. So we'll continue.
Also
having
Tocolysis only if
She's
the
having
pain is there.
funneling.
Yes.
Ma'am,
She is-
tocolysis only if the pain is there.
Ma'am, in fact, the guidelines say that if you do a repeat cerclage, then the risk of preterm are
More.
what they have seen was
Yes.
more in comparison to not doing a repeat cerclage.
Yes.
But there are a few studies. So everybody agrees that repeat encirclage need not be done. But there are few case studies which says that you can do, though RCOG guidelines say you do a repeat encirclage, there are more chances of preterm delivery. But there are certain guidelines which say, case studies say that you could do a repeat encirclage. And here we did a repeat encirclage for this particular person because cervix was so short, and then we so in spite of the repeat encirclage, she delivered at 28 weeks. We could continue the pregnancy for another almost 8 weeks. We could continue the pregnancy for 8 weeks. And this we've done repeat encirclage on 2 or 3 occasions in a hospital. And all of them we found it very successful. Now this particular person, she's had one preterm miscarriage at 24 weeks. And the second one, in spite of 2 encirclages, she's had a preterm delivery at 28 weeks.
Ma'am, just a second, ma'am, in repeat encirclage, if you do, ma'am, in that case, you do a McDonald, or in that case, you go for a modified Shirodkar in that case?
We do the Shirodkar. We do the Shirodkar because there's no point. Next suture should be on higher above that. Now, so it's no point in just trying, whatever you've done lower, it should be above that.
Yeah.
So we've done it on 3 or 4 occasions. And we found it to be very useful. In fact, we thought we were almost given up. And then we did the repeat encirclage. 2 of them came as emergency. And then almost just 1 centimeter short. And then repeat encirclage was very successful.
Ma'am, you do a Shirodkar or a modified, that is, you only open the upper bladder reflection. Posteriorly, you do not open up.
I do them more. And now, when I went recently for a conference there, they have a very nice needle. It's just a straight tip. You just put the needle and then you can even use a cotton tape. In fact, I wanted to get a video, I could not. And you just take it out, just 2 pokes, and then you can just bring it out and thread it. So it's extremely very, very useful. You don't, because when you use this needle, it's very difficult when you come to the sides, when you do the McDonald's or whatever, it's very difficult because our needle is a round body and you should get the correct diameter. So it might be very difficult sometimes. And we found this needle, it's like a needle carrier with the thread. I'll post it sometimes once in this group, I'll post it so that you can have a look at it. So it just, it's a poke, you just make a poke with this and then thread the needle onto the thing. It just bring it out. The same thing, you make another poke at the other side and just tie it. So it's just over in 5 minutes. It's extremely simple. Now, so this person who's had such a bad obstetric history, one preterm delivery at 16 weeks, another one at 28 weeks after 2 encirclages. How are you going to plan her next pregnancy? Because before encountering the pregnancy, she's going to be extremely terrified. So she's going to come to you and tell you what the same thing is going to occur. How I'm going to plan my next pregnancy. So, Dr. Amrita, what will you tell her? What will be your plan? Let's forget about the what will be your plan?
Yes, ma'am. She should be investigated in detail now for repeated pregnancy loss also. Her and besides her routine tests, the diabetes workup, the thyroid workup, her antiphospholipid antibody, and even the torch infection should be done and assessed. Her vaginal infections should be treated, seen and treated for chlamydia, etc. She should be assessed. And she should be told that she would be needing an abdominal cerclage in the 3rd pregnancy.
Next pregnancy.
Yes.
So would all of you agree that you would plan to do an abdominal encirclage? Okay, next pregnancy. So now, Dr. Amrita, would you like to do the encirclage before she gets pregnant or after she gets pregnant?
Ma'am, both can be done. I mean, it is her choice what she wants.
So both
can be done.
So there's no contraindication saying that you should not do it before pregnancy. If she wants, she could do it earlier on. So definitely so this is the ideal case where you do an abdominal encirclage because repeatedly it has failed. So you tell her that you only have to have an abdominal encirclage. Like shown in this picture, a trans-abdominal cerclage, you'll be able to place the suture exactly at the level of the interlars, whereas that cannot be done even in your So always in such cases, it's best to go in for an abdominal. You could either, what route would you opt? Anybody, one of them? Dr. Amrita finished. Dr. Amber, what route would you choose?
Both the routes have similar efficacy, but because of lesser complications and all, the laparoscopic route is preferred.
So it just depends upon in what you're more confident in. You can, if you're not very good 16 weeks, if you want to do an encerclage around 13 weeks. And what time would you do?
Ma'am, we can do it before pregnancy, and during pregnancy, it can be done between 11 to 14 weeks.
Okay, so like any other case, you would, irrespective of the cervical length, will you do, or will you wait for the cervical length to become short?
No, ma'am, we will do
irrespective. You will stay irrespective of what is the cervical length. You will definitely do it. So 12 to 14 weeks would be ideal after your NT scan. That will be the time. So it depends upon what you could do. You could do an open or a laparoscopy. But what would be the problems in this transabdominal encerclage when compared to your chirurgicals? What would be your main problem?
The patient will have to deliver by cesarean section.
A cesarean section only, because the knot is inside. You have to only deliver her by a cesarean section. But anyway, it's worth the cesarean section because the cervical os would remain closed. Okay, so this is sutured by an image showing your laparoscopic encerclage. Okay. So there are lots of things we have not discussed about twins, because twins and encerclage is very, very controversial. In fact, the guidelines say no encerclage for twins. But that is not something that everybody does encerclage for twins. So let's not go into the very controversial details. So we've sort of covered the indications for an encerclage, how we do the encerclage, what are the different techniques, and how we'll follow these patients for encerclage, and about a transabdominal encerclage. Though there is a little more, since we don't have any time, I thought we would wind up. Dr. Sadhana could give your take-home messages.
Yes, before that, I would just like to ask one question from the panelist. Yeah, anyone can answer. Suppose in a patient, it's a primary gavda, you are just doing a routine ultrasound, and you find that there's a funneling of internal os. Would you like to do a cerclage? What will be your approach?
No, ma'am.
Just
With a normal
what would you like to see?
Cervical length is
that is more important. If the length is normal, we are not going to give any cerclage. So the take-home message is, Dr. Chitra, in singleton pregnancy, if there's no risk factor, cervix is short even, then also you have to just follow with the ultrasound, serial ultrasound surveillance, 2 to 4 weeks. Singleton pregnancy with 3 preterm births, of course, you have to do a cerclage. Singleton pregnancy with preterm labor, serial shortening, then you have to do cerclage. And if the previous transvaginal cerclage, as in this case, have failed, of course, you have to do abdominal. But in abdominal cerclage, we have to also remember that suppose, unfortunately, patient goes into, has an IUD, which could be a late 2nd trimester or in the 3rd trimester. In that case, either you need to remove the stitches through colpotomy. If it fails, then hysterectomy has to be done. So it's very important to do the counseling in all these cases if you are giving a transabdominal cerclage. And of course, you have to identify the risk factor. Dr. Amber has very nicely elaborated in the beginning. So this is a never-ending topic. We are going to, I think, finish it now. Dr. Chitra.
Ma'am, there is one pessary kind of a thing which is called Arabian pessary. So I have had an experience of using that.
Ma'am, since we are Sadhana, ma'am, since we are discussing about the cerclage only, let's have some discussion about the twin also. Though Madam has said that it is controversial, but what message go? The message and the guidelines. The patient can, sue us for not putting or for putting. What should be the?
I think it's again. There's no consensus right now. Timing of the cerclage, what technique, and when we should give cerclage, because patients are well read and they are going to see this. Definitely you can go.
The FIGO guideline mentions that if the cervical length is less than 15 millimeters in twins, 1.5 cerclage should be applied.
Yes, ma'am.
But RCOG says it's controversial.
Yeah, it's controversial, but FIGO says that if it is less than 15, Otherwise,
yes.
we are taking the cutoff as
So
25
we can
millimeters.
quote both,
25,
but we are
yes.
doing
We
both
take it
ways.
as 15
Yes,
millimeters.
we should
Yeah.
do it. Yes, it is individual
Sometimes
choice.
it
Yes.
triggers the preterm labor even.
Now, could Dr. Amrita share your experience regarding the Alevin pessary?
Ma'am, I've just put 2 and I was successful with 1 case, ma'am.
Okay.
So, that's
And about atosiban also, Dr. Amrita, we want
yes.
to know. We have never used it. Yeah.
Atosiban I've given only twice and just 1 shot, single injection, 3.75 milligrams. And
Okay.
one was in the case accidentally, I had written injection sustained for the patient and the staff gave injection Syntocin onto that patient.
Oh my God.
Yes, ma'am. And then I rushed
Oh.
and I called up the company person and he came with the injection and it worked, ma'am. And the patient continued.
Only one single dose. One
Oxytocin
single
Yes,
antagonist.
ma'am.
Single
Only the
dose of
single
Atosiban I have given
shot
2 patients.
worked.
Quick
So I
thinking,
had
quick
experience
thinking.
of 2 cases, madam. I had atosiban 2 cases.
Okay. Okay.
I have given 1 patient at 30 weeks and she prolonged for a week because we have tried with her all the other parameters. She has already been cerclage done. We have removed everything. She went in for an intractable labor, but we could prolong it for a 1 week so that we have time for steroid. We have time for max self, everything that went on and the baby survived the NICU.
So, ma'am, you
Probably-
continued atosiban for 1 week. The drip.
Yes.
1 single shot.
1 single shot, and after that we
Single shot.
continued after 48 hours, 1 more
Yeah.
shot I gave.
Acha, 2 shots you gave.
Yeah.
Yes. Atosiban only for 48 hours, ma'am. It is not to be given.
It won't
for
work
long
beyond
period.
that, only 2 doses.
But they say you don't have to give it continuously. Like when you
Yes,
want
ma'am.
to give only acute tuberculosis, is enough. We just give a single.
All the tuberculosis, yeah, they need to
have
be
to
done only
go
for 48 hours.
48
Yes,
hours.
maybe
Because-
dip in, yeah, everything
Yeah.
for 48 hours. Yes.
And I've also used this Arabian pessary and found it quite useful. I used it for 1 case, and it's very easy to use the pessary. There are studies which looks very promising and is as effective as your progesterones. Now we say progesterones are as effective as encerclage. So equating all those things, Arabian pessary, progesterones, and encerclage should be on the same platform shortly. Unless we start using it, we will not be able to share our experience and come out with more data. So,
ma'am, 1 minute, ma'am. There are some questions in the box, chat box. Which suture material is best in case of rescue cerclage?
suture material, I use only the tape, Marceline tape.
Rescue
No, but you know, I have used
But
Proline,
if
and
you
it
use
was
it
successful.
McDonald's, you
It
could
was
still, it
successful.
depends upon
Proline.
how much of length you're able to get.
Yes, because in rescue cerclage, you can't
Whenever we
apply
use
muslin.
McDonald's, we use the Proline.
Yeah, I have used Proline successfully, and that patient continued till 37 weeks. It
So
was a
yeah.
rescue cerclage because muslin tape won't have that much of space, you know.
Yeah,
Hardly
it
there
is
is
broad.
surface. Yeah.
Actually, it's
Yeah.
broad.
So
That's-
I use Proline, and it's very good effect. Yes.
Kindly explain the lash suture and worm suture.
But a worm suture it's an occlusion suture. See, when the cervix is closed, it's open like this, you may not be able to do your McDonald's like this. So it's occlusion. Do it from top to bottom, anterior to posterior. That is the way you do the suture.
What about the usage of Maxelf in preterm labor with cervical cerclage? Use of Maxelf.
Maxelf should only be given for 2 things. It can be used as a tuberculosis, but at the same time, if the person gets into labor, then you use it for neuroprotection. But
Neuroprotection is very important. Yeah, we should give.
Tuberculosis.
Basically,
When you want to give it for
neuroprotection.
tuberculosis, it may not be very good. It's more for
Basically for neuroprotection. Yes. Yes.
Yeah, ma'am. Those were the questions in the box. Questions.
So, ma'am, one thing I want to ask that if you apply a rescue cerclage, would you apply a repeat rescue cerclage also by Shirodkar if the patient comes in labor?
No.
It won't be possible. She
No.
will come with an expulsion. You cannot survive
no,
with
yeah.
a rescue.
Yes,
Once
yes.
it is there, already
Rescue,
she's
yes,
open.
Yes, yes.
Many
yes,
a times
yes.
it will be a real struggle.
And
We
ma'am,
can
for
postpone
repeat
for a few days.
cerclage, for repeat cerclage, do you remove the first one?
No.
No.
No, you just have to go above the first one. There's
Above
no
the
need
first
to
one.
remove it. Even the guidelines say no need to remove it. Just go above the first encerclage.
Thank you.
But sometimes
So you use the second cerclage as a rescue cerclage when you have already applied a history or ultrasound indicated cerclage.
Yes.
Okay.
So
And
usually
after
when there is
applying,
when you apply a surclage, she always come with the preterm labor pains. It will be an intractable preterm contractions. You have to treat her more like a preterm labor and control her with the tocolytics and your preterm labor protocols should be there. Not the surclage will not be effective unless otherwise you control, because already she had a surclage. The emergency or the emergency surclage is always for not a surclage done, but she comes with the bulging membranes. Then your emergency surclage acts or rescue surclage acts. But women already had a surclage. She always comes with a preterm labor. You have to treat her as a preterm labor.
Okay.
So to conclude, it would be nice if we don't have babies which are born preterm, but all these people, Albert Einstein, Isaac Newton, Winston Churchill, all celebrities were all born prematurely. So try our best not to have a preterm delivery. But in case it has, hope that one of them is going to be a great person like this. So
one thing I want to tell you, as almost I'm also doing a lot of 29 years of high risk pregnancies, the cervical length does not have any effect on the internal loss competency, madam. That is a very important one.
That's what,
so never go by the way of a cervical length.
3.6 centimeters.
Because internal loss is the one which gives way. So whenever we do a laparoscopy or a hysteroscopy, check the patency with your Higa's dilator. Make a note of it, that it is easy dilatable or it is a patulous. That will help you for a prediction. And if she's a high risk, always put a cerclage empirically. That will help her to prevent the preterm internal loss opening and the bulging membranes, because the labor is not the problem. The membranes will come out. That is the problem. The os becomes patulous. That, of course, we have to be very careful at the 14 to 16 weeks, because that is the stage that it gets open. Because it's not the length alone. Because many times the patient will come and ask you, madam, my cervical length is 3.4, 3.5. Why you want to say? Because it's the internal loss. The previous day it will be 3.4. The next day she'll come with the bulging membranes, because it's the os that gives way. So you have to be very clear about certain norms, that not the length that matters. It is the valvular mechanism that matters.
It's actually when you in an ultrasound, when you see the funneling of the cervix, that is when you have to see these patients are more prone for preterm labor. And even if they have funneling, you must see what is the length. So that means the internal loss started opening. The effacement has started happening. Okay.
Yes.
So now, so I think
we can stop sharing that. Thanks, everyone. I can stop sharing that.
Thank the organizers for having given us this opportunity, and thank all the panelists for their wonderful.
Thank you, ma'am.
Thank you,
all the
Sadhana ma'am.
delegates.
Thank you, Jaiswal madam. Thank you, Chitra madam, for this enormous, wonderful practical tips, which you have really made it a very good way.
Thank you.
Rani ma'am, thank you.
We also learned a lot from you all.
Thank you, Dr. Jairani, and thank you.
So we just wanted to know how different is the north and the south. Are you all practicing it the same way like we do? And we find that all of us are doing it the same way. On the same practice.
I have 4 or 5 cases where we have a bulging membranes. We put the Foley's catheter. That's the best thing that have a very good effect. So that slowly you push it, because madam showed one picture of the bulging membranes. So you put a Foley's catheter and then just put a head on and then wait so that it goes inside, and then you put a stitch. That will save save it for very many times without puncturing the your membranes. That is a very important one. You can put a slow inflated Foley's catheter and then slowly push it. Then put the stitch.
Push it in a hurry. Patiently push the membrane.
You should do very gently.
Okay, may I say a few words, ma'am, please? Thank you, Chitra ma'am and Dr. Sadhana ma'am. It was such an interesting amalgamation of academics and experience. I mean, when to do, what to do, when not to do, how to do. I mean, you covered all of it, and it was just mesmerizing, ma'am. Thank you so much, and thank you, Jairani ma'am, for making me part of this excellent.
So I need all your support and help for my Foxy elections. I've been senior working more than 20 years in this specialty, and I'm passionate in the reproductive and sexual medicine. So that is why I'm contesting for the second time. I need all your blessings so that we all will work together for the women's sexual health and the reproductive health, which is a very important one that we all should, in future, this is going to be a very important mark in the women's life. So please support me in my electoral, and
Wishing you all the
thank you
best,
so
ma'am.
much.
All the best, ma'am.
All the best.
Thank you
All
so
the best.
much.
Sadhana ma'am, thank you so much. Sadhana ma'am, thank you so much for
joy and pride to
co-moderating.
deliver the vote of thanks,
Attention.
madam. First of all, I would like to thank Dr. Jairani, President Oxy, for making this webinar possible. I'm delighted that we have been able to bring the esteemed members from UP societies to this webinar and listen to their expertise. I extend my warm thanks to Dr. Sadhana Gupta for kindly conceding to be the chief guest and the guest of honors, Dr. Raki Singh and Dr. Preeti Kumar. I am thankful to all the chairpersons, Dr. Kanchan Sharma and Dr. Namrata. Big thank you to the speakers, Dr. Naveen, Dr. Srivatsan. Thank you, Dr. Chitra and Dr. Sadhana, for the engaging panel discussion, and all the enthusiastic panelists, Dr. Ambir Khan, Dr. Amrita, Dr. Aradhana, Dr. Sweta, Dr. Samta, Dr. Uma, and Dr. Shubha. Thank you so much, Dr. Bharani, for that excellent comparing. And thanks to Shield and Ms. Chitrakala for organizing the webinar beautifully. And I thank the audience for their phenomenal response and hope to keep you engaged with more such activities throughout the year. Thank you so much. Thank you.
Thank you, Rajshri. Thank you, Rajshri. All this is because you have made the energetic, I mean, you have done it wonderfully. Thank you, Rajshri.
Thank you.
Thank you so much.
Best wishes with you.